All right, today's date is September 2nd, 2021, and the time is 3:05 p.m. This will be the videotape deposition of Dr. Ronald Schwartz, MD, in the matter of Shirley Couch versus Creative Hospice Care, Inc. et al. Would counsel please identify themselves for the record, after which the court reporter will swear in the witness remotely.
James Potts here on behalf of Shirley Couch.
This is Tom Asiati on behalf of the defendants, with the exception of Dr. James Shiver and Ms. Carol Renee Bonner.
Sharonda Barnes on behalf of Dr. James Shiver.
Amy Cooper on behalf of Ms. Carol Renee Bonner.
All right. Would you raise your right hand, sir? Do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you.
Would you tell us your name, please?
Yes, Ronald Jeffrey Schwartz.
Yes, sir. And are you a medical doctor?
I'm a medical doctor.
Yes, sir. And yes, sir. And how long have you continuously been a medical doctor?
Since 1984.
Yes, sir. And a physician and a medical doctor, are those terms interchangeable?
Yes.
So if we say physician, we're talking about a medical doctor, we're talking about a physician. Is that right?
Yeah, correct.
And where do you work?
I work at the Masonicare Health Center in Wallingford, Connecticut.
Yes, sir. And what is your title at Masonicare?
My current title is the Senior Director for Continuum Health Services.
Yes, sir. And did you previously serve as a medical director?
I did. I'm still the medical director. Currently, I'm the medical director of the entire continuum rather than just one part of the facility.
Yes, sir. And do you supervise other medical directors?
Yes, I do.
All right. And how many other medical directors do you supervise presently?
4 medical directors through hospice, and then 2 associate medical directors at the Masonic Healthcare Center.
Yes, sir. And do you also supervise other physicians?
Yes, I do.
And do you supervise nurses as well?
I do.
And have you done that continuously for at least the last 5 years?
Yes.
How long have you been supervising other physicians and nurses?
25 years.
Yes, sir. And what do you do as medical director and senior director at Masonicare?
Well, I have various roles.
Yes, sir.
And I think I think the way to sort of break down my roles is to kind of maybe break it into 3 parts: the clinical work, my work as a hospice medical director, and my work as a more clinical director or director throughout the continuum.
Yes,
so my clinical work involves multiple levels of care. And where I work at the Masonic Healthcare Center, it's a continuum, which basically means that they have all levels of care, from more independent living, where I work in an outpatient medical practice, to subacute care, where they do rehabilitation. They have acute care hospital, which is a 30-bed hospital. We also have a 30-bed acute and geriatric psychiatric unit, and long-term care of about 400 beds. So I don't run everything. There are other physicians that I supervise and nurse practitioners that I work with, but I have various units in the long-term care unit. I do rehab admissions. I work with the nurses in the medical psych unit as well as the acute care unit. And I have a couple of days a week, I work in the outpatient practice, where I take care of more of the ambulatory patients on the campus. So that's my clinical work. As far as my medical director work, I work as a medical director still for the Masonicare Health Center, which I described as a 400-bed facility with multiple levels of care. And there I work directly with the director of nursing and associate director of nursing and various committees and so forth. And I also now work across the continuum. So without being too verbose about it. Masonic has multiple different assisted living facilities throughout the state of Connecticut. And I serve as a medical director for all these different facilities and work with the nursing supervisors as well as administrators in these facilities. And the final part, I guess I would say, is since 2010, I've been the director for hospice and palliative care through Masonicare. And I basically serve as the senior medical director, and I supervise probably at least over 200 patients throughout different branches throughout Connecticut.
Yes, sir. And those 200 patients, those are hospice patients.
Those are hospice patients, yes.
And Masonicare has cares for hospice patients.
Yes,
And you're the medical director still for the portion of Masonicare that is hospice and cares for hospice patients.
correct.
Yes, sir. And as a hospice medical director, what do you do?
I have various roles, and I guess once again, it would be sort of divided into administrative, supervisory, and direct clinical roles.
Yes, sir.
And I guess for the probably the best way to describe it for administrative roles, I participate directly, as I did this morning, in the hospice. They call it IDT, which is like interdisciplinary team meetings, where we sit with various members of the team, nursing, bereavement counselors, social worker, and so forth. And we review the new admissions as well as reviewing the current hospice patients. And we as well I review medications as well as recertification, which means you review each patient and that's up for recertification and determine whether or not they still meet hospice criteria. So that's part of the administrative duties. I supervise and work along with nursing, and nursing consults me, as they just did a few minutes ago before I got on this call, regarding medications, medication management, questions about various issues regarding hospice patients, pain management, could be, again, deciding on medications, doses of medications, and so forth. And, the final clinical part would be I do take on patients in this role, that particularly patients that don't have physicians, or their physicians aren't comfortable managing hospice patients and they wish to have, the hospice physician, hospice medical director take them over. I'll specifically have them as my own panel of patients, and we'll see them on a regular basis as needed.
Yes, sir. And do you also supervise education there at Yale for the geriatric fellows, residents, and APRN students?
Exactly. So, and that's kind of an overlapping role between hospice and my geriatric role and so forth. They're all kind of interconnected, but I have faculty appointments where I have clinical appointments at Yale, and faculty appointments at University of Connecticut School of Medicine and Quinnipiac University School of Medicine. So we have students that come from Yale actually that do round with us, and I supervise and educate them, particularly in hospice care, and geriatric care, because that's something that is happily being recognized as a more and more important part of medicine and is underrepresented. I do, clinical teaching on a regular basis at it's called the Frank Netter Quinnipiac University School of Medicine and University of Connecticut School of Medicine, both in geriatrics and particularly in hospice, because again, there are not a lot of board certified hospice physicians, and they're looking for physicians to educate students in this regard.
Yes, sir. And are you a board certified physician?
I am.
Yes, sir. And what are your board certifications?
So I'm board certified in internal medicine,
Yes, sir.
geriatric medicine, which is a separate board, and then the third board, hospice and palliative care medicine.
Yes, sir. And were you asked to consider the violations in medical care that put Shirley Couch into a drug-induced coma?
Objection.
You may answer.
I was.
And give an expert opinion regarding how the care offered by Dr. Shiver and the hospice defendant nurses led to Ms. Couch's coma?
I do.
And can you tell us your expert conclusions about this?
Yes, I can.
All right. And
So my
before we get into that, I'd like to talk to you about what makes you, and please tell us what education and experience you had that makes you an expert in this particular kind of case.
Well, again, I've trained in internal medicine going back to 1985
Yes, sir.
for 3 years in New York in the St. Barnabas Hospital, which was affiliated with Cornell and New York Medical College, New York Medical Center. And after that, I did a geriatric fellowship for 2 years in Philadelphia with the Albert Einstein Medical Center and Philadelphia Geriatric Center.
Yes,
And that
sir.
was from 1989 to 1991. I was at St. Barnabas from 1985 to 1988. And then I did a fellowship in internal medicine from 1988 to 1989. And then after finishing my geriatric fellowship, I actually always worked in geriatrics. For a short time, I continued to work. I don't know if it's a short time, but 3 years.
Geriatrics?
Well, it's funny. Geriatrics it's basically the care of an aging adult. They used to say people 65 and older, but again, as people age, that definition isn't as appropriate as just saying senior people with more advancing age. It can be people, as old as the oldest patient I have, who ironically we talked about today on hospice, almost 108, but it's the elderly population, however that's defined. So I, again, after doing my fellowship in geriatrics, I stayed on at the Philadelphia Geriatric Center and Albert Einstein Medical Center.
Yes, sir.
And I worked as an attending physician from about 3 years until 1995. And then from 1995, 26 plus, almost 27 years later, I'm in the same facility in Connecticut at the Masonicare Health Center.
Yes, sir. And are you a member of the American College of Physicians?
I am.
And what is the American College of Physicians?
The American College of Physicians is actually the largest organization for internists, and they help maintain standards of care both clinically, but they offer continuing medical education, scientific meetings. So it's really the foremost organization for internal medicine physicians
Yes, sir.
to stay current in medicine.
And so you've been a member of the American College of Physicians for about 27 years?
Since 1994, yes, that's 27 years. Wow.
And you're also a fellow in the American College of Physicians?
That's correct.
And what is a fellow? I mean, you did your fellowship training. Do you mind explaining for the ladies and gentlemen of the jury what that means?
Sure. Well, a fellow, there's certain more stringent requirements that a physician has to go through to become a fellow in any organization, particularly in the American College of Physicians.
Yes, sir.
So in order to become a fellow, you have to be a member for a certain length of time. Then it might have been 3 to 5 years. I don't remember exactly, but in addition to that, you had to show good standing medically and ethically in the medical community and be recommended. Then you had to be certified by the American Board of Internal Medicine. And then you also had to show evidence of publication and continuing education with students and the like.
Yes, sir. And you've been a fellow with the American College of Physicians for about 24 years. Is that right?
Yes, correct. 1997.
Yes, sir. And you're also a member of the Connecticut Medical Society?
Correct.
And what is the Connecticut Medical Society?
It's a local medical society that meets periodically, and it kind of discusses and updates physicians regarding particular standards of care in the state
Yes,
of
sir.
Connecticut.
And you've been a member of the Connecticut Medical Society for about 26 years, is that right?
Yes,
And you're also a member of the New Haven County Medical Society since about 1995.
right.
And what is a New Haven County Medical Society?
It's a local society. It's made up of physicians that work more in the area, like I do through Yale, and even where I am in Wallingford is considered New Haven County. That's even more specific to the medical issues and standards as they apply to the more local level of medicine.
Yes, sir. And you're also a member of the American Society on Aging, is that right?
Yes.
And what is the American Society on Aging?
Well, that's basically a more global society. It's more of a national society that, again, publishes education, research to kind of educate the public and other physicians regarding the latest standards of care and updates and proper practices in geriatric medicine itself.
Yes, sir. And you're also, and you've been a member of the American Society on Aging for about 23 years, is that right?
Yes,
And you're also a member of the American Medical Association since 1999.
right.
And you're, as you mentioned, a fellow of the American Geriatric Society, and you have been since about 2005.
Correct.
And so that's about 16 years.
Right.
And you're also a board certified hospice physician.
Yes,
And how long have you been a board certified hospice physician?
since 2012.
Yes, sir. I don't know if you could speak up just a hair.
Sure.
Thank you. And you're also a member of the Medical Scientific Advisory Council to the Alzheimer's Association. Is that right?
Correct. Did you
Now,
ask?
I'd like to,
Oh,
sir.
sorry. No, I
That's all
thought you were saying something. I couldn't hear you, so I
Oh, yeah, well,
got nervous for a minute, but now I'm all right.
I'd like to talk to you briefly too about your educational background. When did you receive your Bachelor of Science in Biology?
1980.
Yes, sir. And where was that?
It was from Adelphi University in New York.
Yes, sir. And did you receive any academic honors?
Yes, I graduated cum laude.
Yes, sir. And did you attend medical school?
Yes.
And where did you attend medical school?
Well, for 1 year, I was actually at the University of Guadalajara in Mexico, and then I
Yes, sir.
transferred to Spartan Health Sciences University in the West Indies and graduated in 1984 with a Doctor of Medicine degree.
Yes, sir. And where are you licensed to practice medicine?
Currently in Florida, New York, Connecticut, and Pennsylvania.
Yes, sir. And how long have you been so licensed?
Well, in Florida and Pennsylvania, it was 1988. New York, I think it was 1992, and Connecticut, 1994.
All right. And you did what are called residency programs, is that right?
Yes.
And what is a residency program?
A residency basically is postgraduate education. It's actually where you physically learn clinical skills to be a doctor. You work in,
Yes,
and you have to apply to a hospital, be accepted to a program. The program has to be affiliated with an accredited medical school.
Yes, sir.
And you work in a prescribed curriculum. There's a whole organization called LCSME, like Licensed Medical Continuing Education Program or whatever, and they have certain requirements that a physician needs to complete before they're eligible to take a licensing exam. And once they complete the licensing exam, they're eligible to get a medical license, but then you go further to a next step of taking board examinations.
Yes, sir. And you completed residencies in both internal medicine and geriatric medicine?
Right, with geriatrics, you would call a fellowship, I suppose.
Yes, sir. Now I'd like to talk to you for a moment about your faculty appointments. By faculty appointments, you teach medical students, is that right?
Correct.
And you're a clinical assistant professor at Frank H. Netter School of Medicine?
Yeah, that's also called, it's Frank H. Netter is the physician it's named after, but it's Quinnipiac University in Connecticut.
Yes, sir. And how long have you been a professor there?
Since 2013.
And are you also a clinical assistant professor at the University of Connecticut School of Medicine?
Correct, yes.
And how long have you been a professor there at the University of Connecticut School of Medicine?
Since 1995.
Yes, sir. And you still teach medical students there?
I do.
And you were also a clinical assistant professor at Temple University School of Medicine?
Right, when I was working at the Albert Einstein Medical Center, before I came to Masonicare Health Center, I was working at Philadelphia Geriatrics Center. Albert Einstein Medical Center was I had a teaching appointment at Temple University.
Yes, sir. And what are your current hospital affiliations?
So I'm affiliated with Yale New Haven Hospital, Midstate Medical Center. And I don't have active privileges at University of Connecticut only because it's way up in Farmington and I don't go there, but I have a faculty appointment there.
Yes, sir. But you do have privileges at Yale New Haven Hospital and at Midstate Medical Center.
Active, yes.
I'd like to talk to you now about your professional activities. Now, you previously worked at the Methodist Hospital in Philadelphia, Pennsylvania.
Right, that was for a brief time as a house officer.
Yes, sir.
In other words, after I finished my fellowship, while another job was about to start and kind of moonlighting just to catch up a little bit because of all the time I spent training. It's always good to get extra money. I did that sort of as a second job.
Yes, sir. And you've now been at Masonicare for about a little over 20 years. Is that right?
It's going on 27.
All right. 27. Thank you, Dr. Schwartz. And your years as a hospice specialist and geriatric specialist and internal medicine physician, what work did you do that would be specifically important to you now being able to work on this kind of case?
Well, I virtually spent my entire professional career and even in going back as far as 1985 and internship and residency, we had a large base of nursing home patients in the Bronx that I would see and that I would take care of and treat clinically.
Yes, sir.
As far as my geriatric fellowship, geriatrics and hospice go hand in hand. And unfortunately, people as they get older do get ill, have multiple comorbidities, do need end-of-life discussions and are often put on hospice. So I got experience just from education in the fellowship program. And then as you hear from telling you my background, I've always been in the field of geriatric medicine after finishing training. And from my years of clinical work, I've worked constantly with older patients, treating multiple comorbidities, multiple advanced medical problems as older people will get, cancers, end-stage heart failure, Parkinson's disease, and the like. And, because of all those years of work, even though I didn't do a fellowship in hospice and palliative medicine. And basically it's just a 1-year fellowship. At any rate, I was eligible by my training and my qualifications and experience to submit, my educational background to the American Board of Internal Medicine, Hospice and Palliative Care boards. And I was allowed to sit for the boards and pass them. And it gave me a lot of training formally just in didactics, and it took many courses to prepare for that examination, but it was a very broad education in the fact of multiple areas of hospice and palliative care, pain management, particularly end-of-life diseases, what would qualify you for hospice, what are requirements for to make a hospice diagnosis, what makes up a hospice team, what are the responsibilities of a hospice medical director. So there are multiple diverse topics that are covered both clinically and by experience that I have, and then by education and training to be able to sit and pass these boards. And there are not many board certified geriatricians, let alone hospice and palliative care physicians. But now they've made it a requirement, meaning the American Board of Internal Medicine to sit for a hospice and palliative care boards, that you need to do a 1-year fellowship.
Yes, sir. So you're board certified in hospice care.
Yes.
And you've cared for patients that have been prescribed opioids.
Yes.
You've cared for patients that have been prescribed benzodiazepines.
Yes.
You've cared for patients that have been prescribed antipsychotic medication.
Yes.
And you've also, do you ever prescribe drugs yourself?
Yes.
And when you do you ensure those are prescribed safely
Yes.
and for a medical reason?
Yes.
And that the people administering those drugs administer those properly,
Yes.
monitor the patients properly?
Correct.
And do you agree that before you prescribe a drug or administer a drug, you've got to know what the drug is?
Objection, leading.
You may answer.
Absolutely.
What's that? Do you have to know what the drug does?
Absolutely.
Is it important that you know what the adverse effects are
Absolutely.
and what the contraindications are?
Absolutely.
Yes, sir. And what are all of those things important for physicians and nurses prescribing and administering drugs?
Absolutely.
Is that particularly true for dangerous drugs? Have you ever been an expert witness before?
Yes.
Have you testified on behalf of both physicians and patients?
Yes.
And you've testified as an expert in medical malpractice cases,
Yes.
both plaintiff and defendant?
Yes.
And what I'd like to talk with you now are about let me show you first. I'll show you what's been previously marked as Exhibit 1. And is this your curriculum vitae or CV?
Yes.
And does it accurately reflect your education, experience, and training?
Yes.
And I'll insert a standing objection. We're not agreeing at this time that his CV can go back with the jury or be otherwise admitted as evidence in this case.
Join.
Join.
I couldn't understand you. Do you mind saying that again, please?
I said I am putting an objection on the record to the extent that this exhibit is entered into evidence, and I'm not agreeing at this time that it is able to go back to the jury as evidence in this case.
I understand.
And I've joined.
Thank you. I'd like to talk to you for a moment about the drugs that were prescribed and administered to Shirley Couch in June of 2017 in this case. One group of opioids, one group of drugs was opioids, is that right?
Correct.
Do you remember how many opioids were prescribed and administered to Shirley Couch in June 2017?
I think in total there were 4.
Yes, sir. And are opioids potentially dangerous drugs?
Extremely.
All right. Opioids, you would characterize them as dangerous drugs?
Yes, I would.
And why are opioids dangerous drugs?
An individual opioid drug can, by the way that these drugs work, can suppress respiration, can lead to respiratory arrest if not used properly. But as well, they can suppress functions in the brain and actually cause the brain to shut down, cause a person to become excessively somnolent, even comatose.
Yes, sir. And is that what happened to Shirley Couch in this case?
In my professional opinion, yes.
All right. And was that as a result of the drugs that were prescribed by Dr. Shiver in June of 2017 and administered by Renee Bonner and the hospice nurse defendants?
Absolutely, yes.
I'd like to show you what we'll mark as Exhibit 2 to your deposition. And Exhibit 2 is a Homestead Hospice physician order, and that's dated the 2nd of June 2017, and that's signed by James Michael Shiver, MD. Is that right?
Object.
What's that? I couldn't hear you.
I don't know his signature. It looks like that to me. I can't say I've seen his signature multiple
Yes,
times.
sir.
But that's what I believe.
Right. What did Plaintiff's Exhibit 2, is that a physician's order?
Yes.
And what is a physician's order?
Physician's order is basically a statement, an order from a physician for generally medications. It could be for other types of treatment, but it's generally a physician approving an intervention for a patient.
Yes, sir. And is it your understanding that this is an order of Dr. James Michael Shiver?
Yes.
And do you see this order has Haldol or haloperidol, is that right?
Correct.
And that's for Shirley Couch?
Correct.
And Haldol is an antipsychotic medication, is that right?
Correct.
And it also has morphine?
Correct.
And what type of medicine is morphine? What class of medication, class of drug?
It's an opioid.
All right. And this order also has lorazepam, is that right?
Correct.
And what is a proper classification for the drug lorazepam? Sir?
A benzodiazepine.
Yes, sir. A benzodiazepine is Those are also referred to as benzos. Is that right?
For sure, yes.
Yes, sir. And I want you to, if you can see here, you see where it reads 6/2/2017 on the left? Is that right?
Absolutely.
And is that the date?
Yes.
And can you read the way it reads there next to morphine?
You want me to read it out?
Yes, please.
Okay. Morphine 20 milligram per milliliter solution. Take 5 milligram to 20 milligrams, which is the equivalent of 0.25 milliliters to 1 milliliter, PO or sublingually every 2 hours as needed for pain or shortness of breath.
Yes, sir. And I'm going to show you what we'll mark as Exhibit 3 to your deposition. And can you see Exhibit 3?
Yes, I can. Well, whoops, now I did.
You see Exhibit 3 here?
I do.
And Exhibit 3, that's also a verbal order for Shirley Couch, is that right?
Correct.
And that's dated 6/24/2017.
Correct.
And it's got morphine here as well, is that right?
Correct.
And you see at the bottom where it says physician signature?
I do.
And do you mind reading that?
Physician signature, electronically signed by James M. Shiver, MD, date 6/28/17.
Yes, sir. And what does it mean that Dr. James Michael Shiver signed that physician's order?
That was the drug that he prescribed for Mrs. Couch.
Yes, yes, sir. And it also reads here, do you see where it reads morphine 0.25 to 1 milliliters by mouth every hour, PRN pain?
I do.
SOB, read back and confirmed start date 6/24/2017.
Yes.
And it reads morphine, it reads milliliters, not milligrams. Do you see that?
I do.
And is that how morphine is typically prescribed?
Morphine is dosed in milligrams, but
Yes, sir.
it's given in milliliter solutions, and it can be in different concentration solutions depending
Yes,
on
sir.
the individual's ability to swallow. Some patients can't swallow pills, so they get a higher concentration of morphine under the tongue.
Right. And this concentration was 20 milligrams per milliliter. Is that right?
Correct.
So if we look at and we know that if we look at the pharmacy records, I'm going to show you what's been previously marked as Exhibit 4 to your deposition. And this is a drug record for Shirley Couch, is that right?
Yes.
And it reads patient Shirley Couch. The drug, can you read that, what that says?
I can.
Yes, sir. And what is that?
Morphine sulfate 100 milligram per 5 milliliter solution, strength 100 milligram per 5 milligram.
So if we divide the 100 milligrams by the 5 milliliters, What does that tell us?
Basically, it's a 20 milligram per milliliter solution.
Yes, sir. And can you tell if there are 24 hours in a day and Shirley Couch is getting between 5 and 20 milligrams per hour according to that prescription? Well, first of all, how many milligrams per hour is Dr. Shiver prescribing to Shirley Couch according to that prescription, that doctor's order?
Well, if he wrote 0.25 milliliters to 1 milliliter every hour, that would be equivalent of 5 to 20 milligrams every hour.
Yes, sir. And I'm going to show you what's been previously marked as Exhibit 5. And this is so you take the 25 milliliters per hour times the 20 milligrams per milliliter, and that's 5 to 20 milligrams per hour. Is that right?
That's what it says, yes.
And if it's 5 to 20 milligrams per hour, how many milligrams of morphine did Dr. Shiver prescribe for Shirley Couch per day?
Objection to form, misstates evidence.
You may answer.
It can vary between 120 to 480 milligrams a day.
I couldn't hear you. I want to make sure that according to Dr. Shiver's orders, how many milligrams of morphine did Dr. Shiver prescribe to Shirley Couch in June of 2017?
So are you asking me per day?
Yes, sir.
Per day, it can vary between 120 milligrams to 480 milligrams
Yes, sir.
per day.
And was it below the standard of care for Dr. Shiver to prescribe morphine to Shirley Couch in June of 2017?
Absolutely.
Yes, sir. And can you state to a reasonable degree of medical certainty whether it was below the standard of care for Dr. Shiver to prescribe that much morphine, any morphine at all to Shirley Couch in June 2017?
Absolutely.
And you can state that to a reasonable degree of medical certainty?
Absolutely.
And can you speak up, please? And beyond that, how certain are you?
I'm absolutely certain.
All right. And can you also state to a reasonable degree of medical certainty whether Dr. Shiver prescribing morphine to Shirley Couch in June of 2017 caused her to be taken to Athens Regional Medical Center by ambulance and be diagnosed with a drug-induced coma?
Absolutely.
And that too is to a reasonable degree of medical certainty?
Absolutely.
And beyond that, how certain are you?
I'm absolutely certain.
Now, 120 to 480 milligrams of morphine per day for Shirley Couch. Was it below the standard of care to prescribe that amount of morphine to Shirley Couch?
Absolutely.
And that's to a reasonable degree of medical certainty?
Absolutely.
And was it also below the standard of care to to administer those drugs to Shirley Couch?
Absolutely.
And you can state that to a reasonable degree of medical certainty?
Absolutely.
And beyond that, how certain are you?
I am absolutely certain.
And did the amount of morphine that Shirley Couch was prescribed and administered by Dr. Shiver and the hospice and other defendants in this case contribute to and cause her to be in a drug-induced coma and admitted to a hospital?
Objection, misstates testimony.
Join.
You may answer.
Absolutely.
All right. Was Shirley Couch an opioid naive patient?
Yes.
And what is an opioid naive patient?
By definition, an opioid naive patient is a patient that hasn't been on continuous opioid therapy for at least a week.
Yes, sir. And what is an appropriate dosage of morphine, if it's medically necessary at all, for an opioid naive patient?
I mean, standards say between 2 to 10 milligrams every 4 hours. Usually we're even more conservative and go to more like 5 milligrams at the most every 4 hours till we know how the person is reacting to it. Unless, again, it's an individual clinical situation. If someone has a metastatic cancer and we know cause of pain, it might be a different approach.
Yes, sir. So what's a normal range of morphine for an opioid naive patient?
No more than 2 to 10 milligrams every 4 hours.
Yes, sir. And
As needed.
And Shirley Couch was getting 20 to 80 milligrams every 4 hours?
Yes.
Between 4 and 8 times the normal dose of that one drug alone, just the morphine.
Objection.
Is that right?
Yes.
Now, the nurses, do they have a duty to their patients as well?
Absolutely.
And what is the nurse's duty to her patient?
I mean, the first duty is to do no harm, to protect the patient and to be a safeguard for the patient's well-being.
Yes, sir. And what's a nurse required to do if she sees a physician prescribing, at least 4 to 8 or more times the normal range of a drug to a patient?
Objection.
Join.
Can I answer this?
Sure.
Okay. So everything has a chain of command, and I think what our nurses do, or what I know our nurses do, is they would question me first. And if they didn't get the proper or an answer that they were comfortable with based on their professional training, they go up the chain of command to their supervisor, and the supervisor would go further and until the proper response was given.
Yes, sir. Were the nurses in this case required to advocate on behalf of Shirley Couch?
Absolutely.
Yeah. And did they advocate on behalf of Shirley Couch?
In my opinion, no.
And is that below the standard of nursing care for these nurses?
Absolutely.
And you can say that to a reasonable degree of medical and nursing care?
Yes, I can.
And beyond, to a reasonable degree of certainty of nursing care, and beyond that, how certain are you?
I'm absolutely certain.
And did the nurses' breach of the standard of care, did it also contribute to or cause Shirley Couch to be transported to Athens Regional Medical Center in a drug-induced coma?
Yes.
I'd like to talk to you about hydrocodone. what is hydrocodone? What classification of drug is that?
Another, hydrocodone is an opioid.
I can't hear you, doctor. I'm sorry.
Yeah.
Okay. And was hydrocodone also prescribed to Shirley Couch by Dr. Shiver in June of 2017?
Yes.
And was it below the standard of care for Dr. Shiver to prescribe hydrocodone to Shirley Couch in June of 2017?
Yes.
And is that, can you state that to a reasonable degree of medical certainty?
Absolutely.
And did the prescribing of hydrocodone to Shirley Couch in June of 2017, did that contribute to and cause her drug-induced coma?
Yes.
And can you state that to a reasonable degree of medical certainty?
Absolutely.
Beyond that, how certain are you?
Absolutely certain.
Did the nurses also have an obligation to advocate on behalf of Shirley Couch when it comes to the hydrocodone?
Absolutely.
Did they do that according to your review of the record?
No, they didn't.
Did the nursing care also fall below the standard of care in that regard?
Yes, it did.
And can you say that to a reasonable degree of medical certainty?
Absolutely.
And did the nurses care in that regard that fell below the standard of care also contribute to and cause Shirley Couch's drug-induced coma, which caused her to be transported to Athens Regional Medical Center?
Yes.
Now, in addition to the opioids, morphine, and hydrocodone, was tramadol also administered?
Yes.
And what opioids, morphine, hydrocodone, tramadol, and fentanyl, are those the four opioids that were prescribed and administered to Shirley Couch in June 2017 while she was in hospice care?
Yes.
And was it also below the standard of care for Dr. Shiver to prescribe tramadol to Shirley Couch in June of 2017? I can't.
Yes.
And can you say that to a reasonable degree of medical certainty?
Yes, I can.
And is morphine a dangerous drug?
Yes.
Is hydrocodone a dangerous drug?
Yes.
Is tramadol a dangerous drug?
Yes.
And did Dr. Shiver's prescribing tramadol to Shirley Couch also contribute to and cause Shirley Couch's drug-induced coma?
Yes.
And you can state that to a reasonable degree of medical certainty and probability?
Absolutely.
And beyond that, how certain are you?
I'm absolutely certain.
And were the nurses required to speak up about the tramadol?
Absolutely.
Were the nurses required to speak up about all the opioids, the morphine and the hydrocodone too?
Absolutely.
And did they breach the standard of care by failing to do that?
Yes, they did.
And you can say that to a reasonable degree of medical and nursing certainty?
Yes, I can.
Beyond that, how certain are you?
I'm absolutely certain.
Yes, sir. And did the nurses' failure to speak up on behalf of their patient, Shirley Couch, about the tramadol also contribute to and cause her drug-induced coma and her to be transported to Athens Regional Medical Center?
Yes.
And what about fentanyl? What type of drug is that? What classification?
Opioid.
Sir. And is fentanyl a powerful opioid?
Extremely powerful.
And what of these opioids, the morphine, the hydrocodone, the tramadol, and the fentanyl, which is the most dangerous or the strongest? All right. I'm going to show you what we're going to mark as Exhibit 5 to your deposition. Is that right, Madam Court Reporter?
I believe we're on 6.
All right. As Exhibit 6. I want to show you what's been previously marked as Exhibit 6. Have you ever seen this document before?
Yes, I have.
And what is that photograph?
Yeah, I'm going to object to this exhibit. It is relevant, prejudicial, and inadmissible.
Join.
And I join, and also not properly been authenticated.
You may answer.
What I've learned in various publications from various medical societies, particularly the American Academy of Hospice and Palliative Medicine, what a small amount of fentanyl could be lethal to a person.
Yes, sir. And this photograph, the fentanyl in this photograph relative to that Lincoln Head penny, what could that cause to an opioid naive patient like Shirley Couch, that amount of fentanyl?
Objection, speculation.
Join.
You may answer.
Yeah.
All right, so that's enough fentanyl to kill an opioid naive patient in that
Yeah.
photograph relative to that Lincoln Head penny?
Objection. Calls for
You may-
speculation.
You may answer.
I'm not speculating. I've learned this in medical conferences and in medical review courses, and I agree.
And can you say that, Dr. Schwartz, to a reasonable degree of medical certainty?
Absolutely.
And beyond that, how certain are you?
I am absolutely certain.
Yes, sir. I'm going to show you what's been previously marked as Exhibit, call this one Exhibit 7. Is that right, Madam Court Reporter?
Yep, that's correct.
Great, thank you. I'll show you what's been previously marked as Exhibit 7. Have you ever seen that photograph before?
Same objection for the use of this exhibit.
Join.
Join.
You may answer.
Yes, I have.
And what is that a photograph of, Dr. Schwartz?
Again, it's designed to show you or show physicians really how lethal fentanyl can be compared to other drugs, including heroin.
Yes, sir. And the drug over on the left where there's the most drug in the bottle, what is that?
That's, I think that's the fentanyl.
Same objection.
Join.
Well, the hair, I'm sorry, I got these backwards. I did a poor job of my question.
So
This
the
is-
left is the heroin.
Yes, thank you. And to the right is the fentanyl. Is that
Right.
right?
Yeah, I got
So-
mixed up with what you asked me. I'm sorry.
And it shows how much more heroin it would take, and that's for the jurors, the bottle on the left, than it would fentanyl, which is a bottle on the right, to kill an opioid naive patient. Is that right?
Correct. It's designed, and I've had this in teaching courses as well, because physicians often don't realize how lethal fentanyl can be compared to other drugs.
Yes, sir.
They understand how lethal heroin can be. So it's designed to kind of show a physician how little amount of fentanyl can equal such a larger amount of heroin.
Yes, sir. And you can state that to a reasonable degree of medical certainty
Absolutely.
and
Objection.
beyond. Go ahead. And beyond that, how certain are you?
I'm absolutely certain.
Yes, sir. And when you teach medical students, do you teach them about how dangerous opioids can be?
Definitely.
And do
it's
you
an
teach?
important- I'm sorry. I was just saying it's an important part of a medical school curriculum.
Yes, sir. And what do you teach them about the dangers of opioids?
Basically, if not used correctly, an opioid could kill you. Short of that, it can cause significant harm to a patient.
And what do you teach your medical students about the opioid fentanyl in particular?
Fentanyl should never be given to an opioid naive patient because it could kill the patient.
Yes, sir. And was it below the standard of care for fentanyl to be prescribed to Shirley Couch in June 2017 by Dr. Shiver?
Definitely.
You can state that to a reasonable degree of medical certainty?
Absolutely.
Beyond that, how certain are you?
I'm absolutely certain.
Yes, sir. And was it also below the standard of care for nurses, hospice nurses, and the defendants in this case to administer fentanyl to Shirley Couch in June of 2017?
Yes.
Objection, no
Join.
foundation.
And can you state that to a reasonable degree of medical certainty?
Yes, I can.
And beyond that, how certain are you?
I'm absolutely certain.
And did the prescription and administration of fentanyl by Dr. Shiver and hospice nurses and defendants in this case contribute to and cause Shirley Couch's drug-induced coma and for her to have to be taken by ambulance to Athens Regional Hospital?
Objection.
Objection, this state's testimony. There's no testimony that the hospice or any of its nurses prescribed any medications.
Join.
Yes.
Was it below the standard of care for Dr. Shiver to prescribe fentanyl to Shirley Couch in June 2017?
Absolutely.
And you can state that to a reasonable degree of medical certainty.
Yes.
Was it also below the standard of care for the defendant nurses to administer fentanyl to Shirley Couch in June 2017?
Yes.
And you can state that to a reasonable degree of medical and nursing certainty.
Yes.
And it was also below the standard of care for any non-physician or non-nurse or non-medical or nursing person to administer fentanyl to Shirley Couch while she was in hospice's care in June of 2017.
Objection to the extent it seeks to impose a standard of care upon someone who is not a medical professional.
You may answer.
Yes.
In fact, it'd be a crime, is that right? If
Yeah.
you know.
Same
And can
objection.
you state,
So
Can you state that to a reasonable degree of medical certainty and probability?
Yes.
And did it also contribute to and cause Shirley Couch's drug-induced coma and for her to be transported to Athens Regional Hospital?
Yes.
And you can state that to a reasonable degree of medical certainty?
Yes.
And beyond that, how certain are you?
I'm absolutely certain.
Yes, sir. And I'd like to talk to you. Is that all the opioids that were prescribed by Dr. Shiver to Shirley Couch in June 2017, according to your review of the records?
Tramadol, Norco, fentanyl, morphine.
All right. Were there any others?
I can't recall any others.
Were there any benzodiazepines prescribed to Shirley Couch by Dr. Shiver in June 2017, in addition to the 4 opioids you just mentioned?
Yes.
And what were the benzodiazepines?
Ativan, which is also known as lorazepam,
Yes,
and
sir.
Valium, which is also known as diazepam.
Yes, sir. And are benzodiazepines dangerous drugs?
Yes.
What makes benzodiazepines dangerous drugs?
The benzodiazepines are central nervous system depressants, and actually, not just in hospice, but in geriatric medicine, you learn that it can frequently cause delirium in older people. It can lead to respiratory depression, confusion, disorientation, contribute to falls.
Yes, sir. And was it below the standard of care for Dr. Shiver to prescribe Ativan or lorazepam to Shirley Couch in June 2017?
Absolutely.
Beyond that, how certain can you state that to a reasonable degree of medical certainty?
I can.
Beyond that, how certain are you?
Absolutely certain.
And was it, did Dr. Shiver's breach of the standard of care in that regard also contribute to or cause Shirley Couch's drug-induced coma?
Yes.
Can you also state that to a reasonable degree of medical certainty?
Yes.
And beyond that, how certain are you?
Absolutely certain.
Now, was it also below the standard of care for the hospice nurses, the defendants in this case, to administer Ativan or lorazepam to Shirley Couch in June 2017?
Objection, this state's testimony, facts not in evidence.
Join.
You may answer.
Yes.
And can you state that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely certain.
And did the nurse's administration of Ativan or lorazepam contribute to or cause Shirley Couch's drug-induced coma?
Absolutely.
All right, you can state that to a reasonable degree of medical certainty as well.
Correct.
And if defendant Renee Bonner was administering the Ativan or lorazepam to Shirley Couch, would that have also been a breach of the standard of care?
Objection, again, to the extent it seeks to impose a medical standard of care upon someone who is not a medical practitioner and assumes facts not in evidence.
You may answer.
Yes.
And would it also be below the standard of care for a non-physician and non-nurse to administer opioids, benzodiazepines, and antipsychotics to a patient in home hospice care without proper training and direction by the hospice nurses?
Same objection.
Joined.
And to a reasonable degree of medical certainty, did the administration of the Ativan and the lorazepam to Shirley Couch in June 2017 cause Shirley Couch's drug-induced coma?
Objection.
And you can state that to a reasonable degree of medical certainty.
I can.
And then the other benzodiazepine was diazepam, also known as Valium. Is that right? And I'm sorry, I couldn't hear you, doctor.
Yes.
Yeah. And was Shirley Couch also administered diazepam or Valium in June of 2017 while she was in hospice care?
Yes.
Was it below the standard of care for Shirley Couch to be administered diazepam or Valium in June of 2017 while she was in hospice care?
Yes.
Was it also below the standard of care for Dr. Shiver to prescribe diazepam or Valium to Shirley Couch in June of 2017?
Yes.
And can you state that to a reasonable degree of medical certainty?
Yes, I can.
Beyond that, how certain are you?
Absolutely certain.
And did the prescription and administration of the drugs diazepam or Valium cause Shirley Couch's drug-induced coma?
Yes.
And is that to a reasonable degree of medical certainty as well?
Yes.
And beyond that, how certain are you?
Absolutely certain.
Now, was Shirley Couch also prescribed and administered an antipsychotic?
Yes. Yes, sir.
And what was that, the antipsychotic?
Haldol.
And what is Haldol?
Haldol is an antipsychotic
Yes, sir.
agent used for patients generally with, it's a fairly strong sedative agent. It's used
sir.
sometimes for people with delirium.
And is Haldol a dangerous drug?
Yes.
And what makes Haldol dangerous?
A lot of things can make Haldol dangerous. One of the things actually is something called neuroleptic malignant syndrome, which is when a person is not used to getting an antipsychotic drug, and then they suddenly start to get it, they can get a violent reaction, which is like a nervous system overload where they get high fevers, they get severe rigidity, it leads to muscle breakdown, it can actually cause kidney failure. And that's something that internists, geriatricians, we're always trained to look out for. But beyond that, it can cause it can cause sedation, it can lead to falls, it can cause a person to aspirate, can worsen confusion, can mask symptoms of other types of conditions and medical illnesses.
Yes, sir. And according to your review of Shirley Couch's medical records, was she suffering from any sort of psychosis?
No.
All right. And as an antipsychotic, is that typically prescribed for some sort of psychosis or a psycho?
Yes. Sorry.
And was there any medical reason to prescribe Haldol to Shirley Couch in June 2017?
No.
Was it below the standard of care for Dr. Shiver to prescribe Haldol to Shirley Couch when she was in hospice care in June of 2017?
Yes.
And can you say that to a reasonable degree of medical certainty?
Yes, I can.
And beyond that, how certain are you?
I'm absolutely certain.
And can you say to a reasonable degree of medical certainty that Dr. Shiver prescribing Haldol to Shirley Couch in June of 2017 contributed to and caused her drug-induced coma and her to have to be taken to the Athens Regional Hospital?
Yes.
And was it also below the standard of care for nurses to administer Haldol to a patient that's not suffering from psychosis without speaking up about it?
Yes.
without advocating on behalf of their patient?
Yes.
And you can say that to a reasonable degree of medical certainty as well?
Yes,
Beyond that, how certain are you?
absolutely.
And did the nurse's breach of the standard of care also contribute to the Shirley Couch suffering from a drug-induced coma and being transported to Athens Regional Hospital?
Yes.
All right. Now, you teach medical students about opioids, benzodiazepines, and antipsychotic medicine?
Yes.
And have you ever had any students come to you and say that they're going to administer, 4 opioids, 2 benzodiazepines, and an antipsychotic to an opioid naive patient?
At a school, no.
Sir, I can't hear you.
They would be kicked out of school. Never.
All right. Yes, sir. If you had a physician do anything like this, how would you handle that?
Objection to the form of the question.
You may answer.
It would be receiving disciplinary action.
Yes,
And
sir.
would probably come to there's a process that occurs in all medical with all medical staff and whatever, where they have a due process of a hearing, but it would probably go to a level of a hearing to review their judgment and their clinical practice.
Yes, sir. And if you had a physician that was employed by you, or you supervised, and you saw him do this, would you recommend that physician go before a review of his peers for his conduct? And why would you do that?
Same objection, irrelevant.
You may
Because
answer.
the actions done would put a patient in danger and probably kill him.
Yes, sir. And is it below the standard of care to administer all these drugs to the same patient?
Absolutely.
All right, and why is that?
One drug alone could kill somebody. 4 of them plus these opioids and the Haldol. I think the Haldol was used to treat a reaction to being to Mrs. Couch being over medicated. She probably initially had a dystonic or a initial agitated reaction from so much medication, and eventually it was like masking or trying to treat the symptoms of a drug overdose.
Yes, sir. Have you ever known a physician to administer drugs like this to a patient?
Never.
Before this case, had you even heard of something like this or somebody doing this?
Objection.
You may answer.
To me, this in the 35 years that I've practiced, this is like the most abysmal care I've ever seen.
Yes, sir.
And it's absolutely shocking, and it's the reason that physicians get letters from all different societies, and why there's so much publicity and education about fentanyl in particular, to warn physicians not to do something like this, and mainly to protect patients from physicians who do things like this.
Yes, sir. Now physicians that work with you, they have to be privileged, is that right?
Yes, sir.
And do you require board certifications to have privileges?
We do.
And have you ever had a physician lie to you about his board certification,
Objection.
to your knowledge?
Not to my knowledge, no.
Have you ever heard of a physician lying about his board certifications under oath?
Same objection.
I never have, no.
All right. And is that something that where you work would require disciplinary action?
Objection.
The physician would be dismissed from staff and would be reported to the state medical boards.
Yes, sir. And why would you report a physician like that to the state medical board?
Objection.
The physician lied about, the cardinal thing you can do as a physician is lie about your credentials.
Yes, sir.
It presents a false representation to the patient and to everyone else or your colleagues, and it basically puts the patient in danger.
All right. So we've been going about an hour and a half. You want to take how long? 5-10 minutes? How long a break would you like, Dr. Schwartz?
I mean, I'm a pretty hardy guy, but I mean, I could go till you're finished, and then before they
Okay.
answer me, we could stop so I can.
Okay. Sure. We'll continue. Now, the patient in this case, Shirley Couch, did you review the medical records and the depositions of Dr. Shiver and the defendant nurses in this case?
I did.
And did you review, I'd like to ask you about the records that you reviewed that you relied on in forming your opinions. All right.
Yes.
Did you review certified copies of the hospice records for Shirley Couch from June of 2017?
I did.
Did you rely on those records in formulating your opinions regarding the care?
I did.
Did you review certified copies of the Athens Regional Medical records for Shirley Couch from June and July of 2017?
I did.
Did you rely on those in forming your opinions about the medical care in this case?
I did.
Did you review a certified copy of Dr. Park's records regarding Shirley Couch?
Yes.
Did you rely on those in forming your opinions about the care in this case?
I did.
Did you also review a certified copy of Shirley Couch's pharmacy records applicable to this case?
Yeah.
And did you also review the Couch v. Homestead et al., the case discovery in this case, including defendant's depositions?
Yes.
And the non-defendant case depositions?
Yes.
And the deposition exhibits?
Yes.
And the GBI investigation and investigation exhibits?
Yes.
And DEA, what is the DEA?
It's the Drug Enforcement Authority or agency.
Yes, sir. And did you review DEA publications and photographs?
Yes.
I'd like to talk with you for a moment about the review you performed in Ms. Couch's case. What was the date of Shirley Couch's care in this case? The month.
She was admitted June 1st, 2017 and discharged, I believe it was June 27th, 2017.
Yes, sir. And did you perform a detailed review of the medical records for Shirley Couch?
I did.
And did you, that included the home hospice records regarding Shirley Couch?
Yes.
And did you form opinions about the care in Shirley Couch's case?
I did.
And who was responsible for the safety of Shirley Couch?
All the medical team that took care of her, the entire hospice team.
Yes, sir. And was Dr. Shiver part of that team?
He was the leader of the team as the medical director.
Yes, sir. And the nurses as well?
Absolutely.
Is that something you call a shared responsibility? Is that right?
Exactly. That's why they call it a hospice team,
And why do they call it a hospice team?
because we work together. You need multiple disciplines to take care of a complex hospice patient, and everybody is responsible.
Yes, sir. And based on your review, were you able to determine what happened from June 1st until her discharge at the end of June?
Yes.
And what happened?
Well, To me, it's a very, very sad case, but it's a lady that had been following for years with Dr. Park, and she had medical issues. She, I believe, was 81 at the time, and she had a history of a stroke. I think she had a hemorrhagic stroke, I believe, in 2008, and she was put on after a bit of time. I guess she had another stroke where this was 2013, where she had an ischemic stroke, and she also had a history of multiple deep venous thromboses, which are, I think, 3 or 4, which are clots in the deep vein in your leg. Which the danger there is that if you have a clot in a deep vein in your leg, based on the circulatory pattern, it can break off and go to your lung, causing a pulmonary embolus, which could kill you. So she was on a drug called Coumadin, and she had been on the Coumadin for a number of years. And she had some other more minor medical problems, but nothing really significant aside from, occasionally she may have had a TIA, which means transient ischemic attack. And again, it's of no major consequence in the fact that she didn't have any neurological sequelae from the TIA. She did have some left-sided weakness after the ischemic stroke. At any rate, she ended up having a fall closer to probably 2017, where she had a head injury and needed suturing and so forth. And I guess it was deemed that because of her falling episodes, that she was not safe to continue on Coumadin. So her Coumadin was discontinued. And then, as I understand it, there was a discussion with Dr. Park and I think this daughter, Renee Bonner. And because she was no longer a candidate for Coumadin, she was put on hospice care.
Yes, sir. What was that? Oh, were any of those medical issues what you would consider terminal conditions?
No.
And you can state that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
I'm absolutely certain.
Was Shirley Couch a hospice appropriate patient on June 1st, 2017?
Absolutely not. And just to elaborate, oh, sorry, I was just going to say to fully answer that question, to be hospice appropriate.
Yes, sir.
Physician would have to say that if the disease ran its normal course uninterrupted, the person would have 6 months or less to live. She hadn't had a stroke in 4 or 5 years and was medically stable. There was nothing that could possibly indicate a 6-month prognosis.
Yes, sir. And in that regard, was Shirley Couch a hospice appropriate patient in June of 2017?
Absolutely not.
And you can state that to a reasonable degree of medical certainty?
Absolutely.
Should she have been admitted to hospice?
No.
All right. And is it the medical director's, what's his role in deciding whether a patient's admitted to hospice care or not?
Well, essentially, the medical director is the one that certifies that the patient has 6 months or less to live and has to be able to write a narrative, which I've done even this morning, to indicate why I believe that that is the case, not just signing a paper, but making a clear statement of what the terminal diagnosis is and why the prognosis is 6 months or less.
Yes, sir. And did Dr. Shiver breach his standard of care by suggesting Shirley Couch had a terminal diagnosis and admitting her to hospice care in June of 2017?
Yes.
And can you state that to a reasonable degree of medical certainty?
I can.
Beyond that, how certain are you?
Absolutely certain.
And did Dr. Shiver's breach of the standard of care in that regard cause Shirley Couch's drug-induced coma and her to be transported to the Athens Regional Hospital?
Yes.
And is that something you can also state to a reasonable degree of medical certainty?
I can.
Beyond that, how certain are you?
Absolutely certain.
Now, was Dr. Shiver, I'd like to talk to you just for a moment, was he appropriately trained to be a hospice medical director?
No.
And is that a breach of the standard of care for a hospice like the defendant, Homestead Hospice, in this case, to employ Dr. Shiver as a hospice medical director?
Objection lacks foundation.
You may answer.
Yes.
And why is that?
They could have gotten any doctor off the street. He had no particular training in hospice at all.
Yes, sir. And that's your testimony also to a reasonable degree of medical certainty?
It is.
Beyond that, how certain are you?
I'm absolutely certain.
And did Dr. Shivers, did his lack of training in hospice care, did that contribute to Shirley Couch's drug-induced coma and her being carried to the Athens Regional Hospital?
Objection, relevance, and speculation.
Join.
You may answer.
Yes.
And is that your testimony to a reasonable degree of medical certainty as well?
Same
Yes.
objection.
Join.
Yes, sir.
Yes.
Now, based on your review, can you state to a reasonable degree of medical certainty and probability that the violations that you're sharing with us led to and caused Shirley Couch's drug-induced coma?
Yes.
Objection.
And beyond that, how certain are you?
I'm absolutely certain.
Now, we're talking about these standards of care, and we're using, this legally required language. Is there any difference in a standard of care and a standard or just a rule?
Well, it's a standard of care and a rule are similar. In other words, a standard of care ensures basically that a patient is protected and that a certain level of medical care is delivered to that patient.
Right. And did the defendant nurses in this case violate nursing standards as a patient advocate relative to Shirley Couch?
Definitely.
And can you state that to a reasonable degree of medical and nursing certainty?
Yes, I can.
Beyond that, how certain are you?
Absolutely certain.
And did the nurses violation of the nursing standard of care, in this case, contribute to and cause Shirley Couch's drug-induced coma?
Yes.
And to a reasonable degree of medical certainty and probability, did Dr. Shiver and the hospice nurses' care fall well below the standard of care in this case?
Yes.
And to a reasonable degree of medical certainty and probability, did their violations of the standard of care cause patient Shirley Couch's drug-induced coma?
Yes.
Now, I'd like to walk through the needlessly dangerous violations of the standard of care one at a time.
I object to that statement on the record as it's not a question and it's leading to the extent that you're about to use that as a preface to a question for this witness.
Not join.
Join.
And these questions have been asked and answered.
Did Dr. Shiver have the requisite credentials to be a hospice medical director?
Objection, this has been asked.
All of these have been already asked and answered multiple times.
You may answer.
This is cumulative and violates Rule 408, I believe.
You want her to read the question back, Dr. Schwartz?
No, I just been waiting for the,
I gotcha.
no.
Yes, sir. What was,
No, he didn't.
all right. Was there any medical condition of Shirley Couch that was indicative of severe pain to warrant the drugs that were prescribed by Dr. Shiver and administered by the nurses and Renee Bonner in this case?
No,
Was that too a breach of the standard of care by both Dr. Shiver and the defendant nurses?
yes,
And can you state that to a reasonable degree of medical and nursing certainty?
absolutely.
Beyond that, how certain are you?
I'm absolutely certain.
Was it a breach of the standard of care to prescribe fentanyl to Shirley Couch in this case?
Objection, this has already been asked.
Yes, it was.
And did that cause Shirley Couch's drug-induced coma?
Same objection.
And those opinions are to a reasonable degree of medical certainty?
Yes,
Same
they are.
objection.
Is that, I couldn't hear you.
Yes,
Yeah.
they are.
And are all of your opinions that you're sharing with us today to a reasonable degree of medical certainty
Yes, they are.
and as applicable to nurses to a reasonable degree of nursing certainty?
Yes, they are.
Now, the starting dose of the dose that Dr. Shiver started Shirley Couch on the fentanyl was, how much was it, if you remember?
Well, I thought when she first came in, she was getting 0.25 to 1 milliliter. of
No, fentanyl.
fentanyl. I'm sorry, I thought you said
That's all
morphine.
right.
I'm
Yep.
sorry. The fentanyl was 50 micrograms.
Yes, sir. And what is a medically appropriate starting dose of fentanyl?
Well, I guess the answer to that question is you'd never start fentanyl without first being on another drug for at least a week or 10 days, such as morphine.
Right. And let me, first of all, would you ever start fentanyl in any amount on an opioid naive patient?
Absolutely not. Never.
And that's to a reasonable degree of medical certainty?
Yes, it is.
And why is that?
Because from all the literature that they're trying to educate physicians about, it could kill somebody.
Yes, sir. And assuming it was appropriate to even start fentanyl on a patient, what's the maximum starting dose of fentanyl that you would use?
I mean, that I would use would be 12 micrograms. Some would say 25, but I would start at 12 micrograms at the most.
Yes, sir. And he started with 50 micrograms
Yes,
in an opioid naive patient.
yes,
So that was at least 4 times an appropriate starting dose.
yes,
And that was below the standard of care.
yes,
That's still a reasonable degree of medical certainty.
yes,
And that also caused Shirley Couch's drug-induced coma and her to have to be carried from hospice to the Athens Regional Hospital.
yes.
Now, the ABIM stands for what?
American Board of Internal Medicine.
Yes, sir. And are there also boards for hospice and palliative care?
Yes.
And what does and you're a member of the internal medicine boards, you have your internal medicine boards and the hospice and palliative care boards, right?
Correct. And the geriatric boards.
Yes, sir. And what do what does ABIM and the hospice and palliative care boards say about the dangers of opioids, including fentanyl, benzodiazepines, and antipsychotic medicine like we have here?
Objection, hearsay.
You may answer.
Absolutely not hearsay. I take board examinations and I take board review courses and I participate in continuing education. And
Yes, sir.
you have to sign attestations that you participate in these kinds of attestations. And they
Yes,
talk
sir.
about the dangers of these kinds of drugs, how misuse and overuse can cause death, which is about the most serious thing and harm you can do to a patient.
And these are things that you know from your education, training, and experience, and your membership in the American Boards of Internal Medicine, the hospice and palliative care boards, and the geriatric medical boards.
Exactly. These questions are asked on the boards, all of these boards, not
Yes,
just
sir.
one, all of these boards.
And tell us why these drugs are extremely dangerous, the ones that were prescribed and administered to Shirley Couch in June of 2017 while she was in hospice care.
First of all, she had no medical indication to need the drugs. Second of all, individually, the drugs could cause, at the minimum, confusion, sedation, could lead to respiratory depression. Additively, you get multiple effects. So it's like, it isn't just like even 1 times 1 or 1 times 2, but it's multiples. It would be 10, 20 times the effect with multiple drugs as if you just had one drug.
Yes, sir. And Shirley Couch's respiratory rate from the medical records, do you remember what it was?
Which date? Objection. You talking about the whole month?
You may answer.
Well, I know at one point her respirations were suppressed. I just don't remember the specifics, to be honest. There were so many different pages.
Yes, sir. And can you be given all these types of drugs and you still have a normal respiratory rate? And if so, how is that possible?
First of all, I've never seen anybody get these many drugs in one person and still be alive. So
Yes, sir.
I guess that would be my main answer to the question, to be like, and you know, if temporarily, the person were extremely agitated from like an initial drug overdose symptoms, and then we're starting to calm down, it might kind of not reflect the full respiratory depression immediately, but there's no way a person wouldn't show signs of worsening respiratory depression over time.
Yes, sir. And do you recall whether Shirley Couch had supplemental oxygen when she was in hospice care?
She did.
And how would that supplemental oxygen affect, one, surviving this onslaught of drugs, and 2, her respiratory rate in light of being administered 4 opioids, 2 benzodiazepines, and an antipsychotic medicine?
Well, I think the answer to that is that she had no significant medical condition before all these drugs were administered to warrant oxygen in the first place. It wasn't that she was in heart failure. It wasn't that she had obstructive lung disease or any other condition that I could see.
Yes, sir.
The only thing that would logically make sense medically is that all these medications interacting suppressed her respiration and caused her to need supplemental oxygen.
All right. And if you would, Dr. Schwartz, can you summarize your findings for us about how Dr. Shiver in particular and the hospice defendant nurses and the non-medical and nursing defendants care fell below the standard of medical and nursing care or otherwise, and contributed to and caused Shirley Couch's medically induced coma?
Objection to any opinions outside the scope, specifically to those who are not medical professionals.
I'm going to object. It's a compound question. It asks for a narrative, and also it has been asked and answered multiple times.
Join.
Dr. Schwartz, would you summarize your findings in this case for us?
Same objection.
Join.
Can I summarize?
Yes, sir.
Okay. So Shirley Couch, I'll try to do this succinctly because it's quite, as we talked about, quite a case. But Shirley Couch, in my opinion, was an unfortunate lady in that she really was was in stable medical health aside from remote histories of stroke that unfortunately, and I believe misappropriately, was put on hospice care, wasn't evaluated by the physician before being put on hospice care, and was started on multiple narcotic agents and benzodiazepines on admission without ever being evaluated by a physician. And I'm not saying that I evaluate every patient that comes in medically, but over time, as she started to get more and more narcotics and already had benzodiazepines, but she was given, in addition to morphine and Ativan and diazepine on admission, she was eventually given Norco, which didn't seem to, which then parlayed her into becoming more, I believe, agitated. And the reason she was becoming agitated was she was over-medicated and had no reason either to be on hospice or to have pain. There was nothing clearly describing the pain that she had. And then on top of that, she was given Haldol to kind of mask the agitation, which comes from having an excess of opioid medication. So basically she was medicated for symptoms of an overdose rather than having the drug stopped to prevent the overdose. And ultimately, I guess the point that I would make is that hospice has 4 levels of care. And to briefly state them without going, there's routine hospice care, which is what Mrs. Couch was on, which is just, routine, seeing a nurse periodically and somebody that doesn't need more intensive therapy. Then there's continuous care, which when somebody is in more distress and they're having more difficulty controlling symptoms, in an effort to keep a person at home, they have Medicare will allow like 8 hours of continuous care, 4 of which has to be done by a registered nurse or a nurse. I believe it's a registered nurse. And the 3rd level is inpatient hospice care, or they call it GIP, general inpatient care, where this is a person is admitted to a facility and the facility has to have a registered nurse on staff 24 hours, 7 days a week. The reason that they have these kinds of levels of care is to treat unmanageable symptoms and prevent a person from suffering, but also dying in an inappropriate setting. And I don't think Mrs. Couch had, I think it was basically, like I call it, like a terminal sedation, that she was put in a state of almost a coma. But if in fact, and I don't believe this is the case, but if in fact she had such a severe symptoms that it couldn't be managed in the setting she was in and needed that degree of medication, that's what she should have been, it should never have been given in a home setting, and she should have been moved to a inpatient level of care. And this is why hospice has these services available. I think that it just, again, she was just treated with more and more medications. Nursing didn't object. Nursing didn't take it up the chain of command. The physician didn't have the training he needed or whatever to evaluate her properly. Ultimately, she needed oxygen, went into a coma, was evaluated at Athens Medical Center, where the doctor there, in her clinical opinion, felt that this was the cause. And 2 days later, she's awake and sitting up and wondering what happened to her. And 5 years later, despite all this and being 5 years older, she's still alive.
Yes, sir. I'm going to have to take a short men's group break. 5 minutes work. Yep.
The time is 4:55 p.m. and we're now off the record. The time is 5:08 p.m. and we're back on the record.
That's all I have.
Hi, Dr. Schwartz. My name is Sharonda Barnes. I represent Dr. James Shiver in this case. Okay?
Okay.
All right. You were retained to review this case in May of 2020. Is that correct?
I don't have it memorized, the exact month and date, I believe so.
Does that sound accurate, the summer of 2020 in which you were retained in this case?
I think so, yeah.
And do you believe you've reviewed all of the information necessary in order to give reliable opinions in this case?
Yes.
As part of your determination that Miss Couch was opioid naive, tell me what you reviewed in order to formulate that opinion.
I reviewed records from Dr. Parks prior to her admission to Homestead Hospice.
And Dr. Parks began treating Miss Couch in 2013, correct?
Yes.
What did you do to apprise yourself of what medications Miss Couch had received prior to 2013?
An opioid naive patient would have nothing to do with something prior to 2013. It doesn't make any sense. In other words, it's so many years ago, if she wasn't taking anything, it would only apply to something within a year, not even a year.
Respectfully, sir, that wasn't my question. My question was, what did you do to apprise yourself of what medications Miss Couch was taking prior to 2013?
I looked at the records that I had, and the records went back to about 2013, I think it was 2013.
Did you note that at least as of 2013, Miss Couch had been prescribed Percocet?
No.
Did you note that well, you did state that you had reviewed Dr. Park's deposition testimony, correct?
Yes.
And you didn't note that in your review of Dr. Park's deposition testimony either?
I don't recall that, no.
And what type of medication is Percocet?
Percocet is a mixture of oxycodone and Tylenol, so it's an opioid.
As early as 2011, Miss Couch had been prescribed tramadol as well, correct?
The records that I reviewed went back to about 2013, so I don't know that I can answer that question.
Did you note in Dr. Park's records that he prescribed tramadol as early as 2014?
Yes.
And did you note that Ms. Couch had previously been prescribed hydrocodone?
I recognize the tramadol, I don't recognize the hydrocodone.
Did you see that Ms. Couch had previously been prescribed lorazepam?
I believe I do recall her being prescribed lorazepam in the past, yes.
Did you review in the records where as early as 2014, Ms. Couch had been prescribed oxycodone?
I don't recall seeing oxycodone, I only recall seeing tramadol.
What type of medication is oxycodone?
Oxycodone is an opioid.
And you didn't take any efforts to review any of her CVS records or any of her other pharmacy records in order to determine what opioid medication she could have been prescribed outside of Dr. Park's office, correct?
I'm not sure I understand the question. Going back, you asking about a specific date and time?
Correct. You've not reviewed any pharmacology records
No.
related to Ms. Couch, correct?
Correct.
We talked about Dr. Park and that she began treating with Dr. Park in 2013 for primary care services, correct?
Yes.
And did you review in Dr. Park's deposition testimony where he talked about from 2013 to 2017, when he was treating Ms. Couch, he testified that her care was declining and deteriorating? Do you recall that?
I do.
Okay. When she first presented to Dr. Park in 2013, she was diagnosed with osteoarthritis, correct?
Yes.
She had a history of osteoarthritis, actually, correct?
Correct.
She also had a history of hypertension, correct?
Yes.
She had a history of vertigo, correct?
Vertigo, I believe so. I don't recall that exactly, but yeah.
She had a history of hyperlipidemia, correct?
Yes.
She had a history of B12 deficiency anemia, correct?
Yes.
She had a history of cerebrovascular disease, correct?
Yes.
She also had a history of unspecified chest pain, correct?
I believe I saw that, yes.
And then from 2014 to 2017, while she was treating with Dr. Park, she was diagnosed by Dr. Park with peripheral vascular disease in 2014, correct?
Yes.
She was diagnosed with atrial fibrillation in 2015 by Dr. Park, correct?
I only saw one mention of atrial fibrillation, and that was at the time, yes. I saw that written. I didn't see anything else ever mentioned again about it.
And that was in Dr. Park's records as of 2015, correct?
There was one mention in a progress note. I didn't see anything else about it, but correct.
And that was a progress note by Dr. Park, correct?
Yes.
And Dr. Park diagnosed her with end organ deafness in 2015, correct?
End organ deafness?
Yes.
She was deaf. I think I saw that as well. I didn't pay particular attention to it.
She was also diagnosed with deep vein thrombosis of the lower limbs in 2016, correct?
Yes.
And she was also diagnosed with experiencing fatigue as of 2017, correct?
I believe so, yes.
And in May of 2017, Dr. Park performed an independent evaluation of Ms. Couch and determined that she was hospice appropriate, correct?
The record says, yes.
Was that what you've reviewed in the record, sir?
Yeah, that he performed an independent review and felt she was hospice appropriate. That's what you're asking me?
That is it. That is what I'm asking you.
Yeah.
And that actually started her admission into Homestead Hospice, correct?
Yes.
Was Dr. Parks first making the determination that he felt like she was a hospice appropriate patient, correct?
Yes.
That is what started that process.
Yes.
Okay. And have you reviewed the hospice certification that was signed by Dr. Park?
Yes.
Okay. So you've given testimony earlier today that you believe it was a violation of the standard of care for someone to sign off that Ms. Couch was a hospice appropriate patient. Are you therefore critical of Dr. Park for signing off on Ms. Couch being a patient that he recommended for hospice?
I wouldn't have signed off, and I guess I would be critical that I don't think she had any hospice terminal diagnosis. So I guess the answer would be yes.
So it's your testimony then that Dr. Park also violated the standard of care?
I think that he signed a certification for terminal illness in a person that I don't believe had any sign of a terminal illness and is still alive 5 years later.
So if Dr. Shiver violated the standard of care by signing that certification of terminal illness, then I would understand your testimony would also be then Dr. Park also violated the standard of care by signing that certification of terminal illness, correct?
I didn't think this case was about Dr. Park, but about Dr. Shiver, so I don't know that I can comment on that.
You can comment on it, sir, and if you would just answer my question.
Object to the form of the question. You're retained to comment on the care of the defendants in this case. We did not retain him to opine on the care of Dr. Park.
His testimony.
Are you employing him now to do that?
No, I'm not. But James, as you know, his testimony is not just limited to what you retain him to. I'm able to cross-examine him on those opinions and see if he shares those same opinions as it relates to other healthcare providers, whether they're named as defendants in this case or not. Your objection is on the record. Dr. Schwartz.
Object to the form of the question. You're
Okay.
asking Dr. Schwartz about opinions that he said that he is not here to opine on of other physicians. He has not looked at the medical records for Shirley Couch. He has not looked at the records for Dr. Park or Athens Regional Medical Center or the GBI investigation or the GBI exhibits or these depositions, the deposition exhibits, the case and the case discovery with an eye toward examining Dr. Park and what he did or did not do, knowing he is not a medical director, he's not a hospice physician, and he is not employed by hospice in this case and was not employed to make a hospice determination in this case. Subject to that objection, you may ask.
If you need to object and you're going to go that lengthy and coach your witness, then I'm going to ask him to leave the room until you finish your objection.
Object to that as well.
That is inappropriate.
If you have an objection, make it.
I'm trying to perfect my objection, but you've interrupted me.
This is an objection on the record.
That's what I'm trying to do, is voice my objection. If you have an objection, you need to limit it so that you're not coaching.
No, sir, you don't instruct me what to do and how to conduct a deposition. If you have an objection, you make it. You don't instruct me what to do, sir.
If the objection is going to go beyond stating what the basis is of your objection, then I'll ask that the witness be excused until such time as the attorneys resolve what the issue is so that the witness is not coached on how to respond to questions.
And I would join in that objection. So Dr. Schwartz, going back to the question that I asked you, given that you believe Dr. Shiver violated the standard of care by signing the hospice certification in this case, and Dr. Park, as her primary care physician, also signed the same hospice certification of terminal illness in this case, do you believe that Dr. Park also violated the standard of care?
Answer that yes or no.
I'm sorry?
Same objection.
And answer that yes or no.
And why can't you answer that yes or no?
Because I haven't reviewed enough of the records of Dr. Park to make a comment on that.
Well, sir, you just testified a moment ago that you reviewed the medical records of Dr. Park, did you not?
I didn't say I reviewed every single record.
I'm not asking about every single record. You gave the opinion that you reviewed the medical record of Dr. Park to determine what her status was as of May of 2017 in order to render the opinion that she was not a hospice appropriate patient. So the question really is, was she a hospice appropriate patient in 2017, sir?
No, I don't believe she was.
So would it be a violation of the standard of care for someone to sign off on her being a hospice appropriate patient in the summer of 2017?
I think that would be up to his opinion. I'm not here to make an opinion on Dr. Park.
So is it also up to Dr. Shiver's opinion then as well?
I'm sorry, I didn't understand your question.
You said it's up to Dr. Park, his evaluation and his opinion as to whether or not he felt like she was hospice appropriate. So I'm saying, are you extending that same courtesy to my client, Dr. Shiver, that it's up to his opinion and his judgment as to whether she was hospice appropriate?
Object for the question.
As I understood it, I was here to review Dr. Shiver's care and the homestead care, not Dr. Park's care. So I don't feel it's fair for me to comment on Dr. Parks when I reviewed Dr. Shiver's records and didn't form an opinion before you're asking me this.
I'm not asking you to form an opinion related to the totality of Dr. Parks' care. I'm asking you to form an opinion, which I understand you've already done, as to whether or not Shirley Couch was a hospice appropriate. Sir, let me finish my question if I can. whether or not Shirley Couch was a hospice appropriate patient in the summer of 2017. What I understand is that you're willing to offer an opinion as it relates to that as to Dr. Shiver, but for some reason you're unwilling to answer that question as it relates to Dr. Park. Is that fair?
Object to the form of the question.
Should I answer this or no?
Yes, you should answer it.
You don't instruct the witness about whether to answer the question. If it's a question Dr. Schwartz can answer, he can answer my objections on the record.
Thank you. Yes, you can answer, Dr. Schwartz.
I believe that Mrs. Couch was not a hospice appropriate patient. And if Dr. Park signed off on that, I don't believe that was appropriate.
Thank you, sir. All right, I want to turn to some of your opinions that you provided in this case as it relates to the medications that were administered to Shirley Couch, or excuse me, prescribed to Shirley Couch in June of 2017. But first, I want to get some general things on the record as it relates to your experience with these medications, okay?
Sure.
You've prescribed morphine in your practice to hospice patients, correct?
Correct.
You've also prescribed haloperidol in your practice to your hospice patients, correct?
Correct.
You've also prescribed lorazepam or a benzodiazepine in your practice to hospice patients, correct?
Correct.
And you've also prescribed tramadol in your practice to hospice patients, correct?
Correct.
And you've also prescribed fentanyl in your practice to hospice patients, correct?
Yes, correct.
And you've also prescribed hydrocodone to patients in your practice, correct?
Yes.
And I think you testified earlier, you don't personally evaluate every patient prior to their admission to hospice. Is that correct?
Correct.
And as medical director, you rely upon nurses and family members to administer medications to your patients, correct?
Correct.
And if a nurse or family member administers a medication against or inconsistent with your orders, do you believe you are at fault?
I have to ask you to repeat that question. I'm sorry.
If a nurse or family member administers a medication against or inconsistent with your physician orders, do you believe you are at fault in that situation?
Object to the form of the question. It's an improper hypothetical question, leaves out facts and evidence, and has facts that are not in evidence.
You can answer, Dr. Schwartz.
Answering that question, no.
You agree that morphine is a very common medication for patients that have complex pain syndromes, correct?
Yes.
And generally speaking, morphine has a short half-life, correct?
For the types of morphine MS, which lasts 12 hours, and IR, immediate release morphine, which is more like 4 hours.
The morphine that was prescribed in this case had a short half-life, correct?
Yes.
Thank you. You testified earlier that Ms. Couch was prescribed to be given morphine every 2 hours on June 2nd, 2017. You recall that testimony?
Yes.
You sort of...
I thought it was every 4 hours. I'm sorry.
No. Do you need to see the order?
It wouldn't hurt.
Okay, do you have that available to you? Did you bring that with you today?
No.
Okay. Regardless of every...
No, object. If you're going to ask a question and you ask whether he wanted to see the orders, he wants to see the orders before testifying.
James, I appreciate that. We're pulling it up. We're pulling it up. Thank you, James. June 2nd order. you see where it says every 2 hours, correct, Dr. Schwartz?
You're talking about the morphine?
Yes.
Yes, I do.
Okay. And it actually says every 2 hours as needed for pain or shortness of breath, correct?
Yes,
So it's not to be given every 2 hours on the hour, but rather every 2 hours as needed for pain or shortness of breath, correct?
yes.
Thank you. You got the 624 one?
Yeah.
You also testified earlier that Dr. Schreiber on June 24th, 2017 prescribed morphine to be administered every hour. Do you recall that testimony?
Yes.
And we'll pull up that order if you need to see that as well.
Which one?
Keep on going, the more 624. There you go. And that as well was not to be given every hour on the hour, but again, as needed for pain and shortness of breath, correct?
Yeah.
So those calculations that you did earlier as to the amount of morphine that you believe Ms. Couch was given, that was solely based on your assumptions that she was being prescribed or being administered that morphine every 2 hours or every hour, correct?
She could have gotten it every hour. So that was based on the fact that the order allowed it to be given every hour.
You also testified earlier that you believed it was a standard of care violation for Dr. Schreiber to prescribe tramadol, correct?
Don't recall exactly the tramadol in and of itself, but in combination with the other medications.
So is it your testimony that prescribing tramadol in and of itself would not be a violation in the standard of care in this case?
I don't believe Mrs. Couch had any pain that would warrant tramadol.
We talked earlier how Ms. Couch was previously on tramadol, correct?
From what I believe and what I recall from the record, she got a couple of doses, but not like a chronic, always on it every day type of situation.
How did you form that understanding, sir? If you've not reviewed any pharmacy records to determine how often tramadol was filled, please explain to the jury how you've made a determination as to how often Ms. Couch was taking tramadol.
Jack, form of the question.
From what I recall from different records, tramadol was on, and then tramadol was off for multiple months, then on again. There wasn't a consistent order that I recall from reading the chart.
Dr. Park prescribed tramadol to Ms. Couch, though, correct?
Correct.
And was it a violation of the standard of care for him to prescribe tramadol to Ms. Couch?
Not in and of itself.
You also testified that you felt like it was a violation of the standard of care for Dr. Schreiber to prescribe Halidol, correct?
Again, it's taken out of context. It's not just Haldol by itself. It's Haldol based on her clinical presentation.
What was the reason that Dr. Schreiber prescribed Haldol?
Because she was becoming more agitated.
And is agitation a reason to prescribe Haldol?
Not necessarily. You look to see why the person is becoming agitated. Are they having overdose of medications? Are they getting more psychomotor? With all the medicine she was on, she was displaying a degree of agitation that would indicate she was over-medicated and getting a body reaction to it, a neurological reaction to it.
But you didn't personally evaluate Ms. Couch in 2017, correct?
Correct.
And you didn't personally witness her agitations, correct?
Correct.
You You testified on numerous times this afternoon, or numerous occasions this afternoon, that you believe it was a violation of the standard of care for Dr. Shiver to prescribe 4 opioid pain medications to Ms. Couch, correct?
Based on her clinical presentation, yes.
You would agree with me that he did not prescribe them to all be taken at the same time, correct?
They had an additive effect.
But you would agree with me, based upon your review of the Homestead Hospice records, that she was initially placed on morphine and continued to complain of pain, and as such, her pain medication regimen was increased accordingly, correct?
Yes.
You started reviewing medical legal cases in 2009, 2010, correct?
I'm not exactly sure when I started. I started probably maybe around that time when I was a medical director, and they would, law firms would periodically contact me, yes. So probably around that time, maybe 2006.
And you obtained most of your cases through an expert referral source known as National Medical Consultants, correct?
Yes,
And that is an advertising agency that links up medical legal experts such as yourself, correct?
yes,
And at least as of 2019, you had reviewed over 100 cases, correct?
probably so, yes.
And the majority of those cases in which you have been retained on behalf of the plaintiff, correct?
By majority, it's probably maybe 70% plaintiff and 30% defendant.
Do you believe 70% plaintiff is the majority?
70%, 70, yeah, like more plaintiff than defendant.
Correct. That's what majority means?
Yes,
Okay. And you're being paid for your testimony here today, correct?
yes.
Objection on the question.
Do you know how much you've been paid to date for your testimony?
Oh boy. If you give me a minute, I got to think about it, but to date, I'm going to have to take a guess, because I mean, I have a rough estimate if that's what you want, but probably about $1,500, maybe $1,600, something in that range.
Dr. Schwartz, I have that as of May of 2020, you were paid $1,700. Is it your
Okay.
testimony? And that was just as of May of 2020. So is it your testimony that you've been paid less than $1,500 or $1,600 to date?
I told you, I didn't get any payment for, I mean, I have the receipt somewhere, but I didn't get any payment for this trial deposition yet, so I'm not including that. So I didn't put in any invoices for any of the time I'm spending now. I will, but I haven't yet.
And I assume you spent some time preparing for your testimony here today as well.
Oh yeah, quite a bit.
Okay. And so how much do you charge an hour?
$3.75 an hour. I charge. I don't know how much National Medical Consultants, where I work, with Dr. de Blasio, how much they fully charge, but that's what I charge.
And how much time?
That's what I get paid, let's say.
And how much time do you feel like you spent preparing for your testimony here today?
Probably about 10 to 12 hours.
Are you unable to personally attend the trial of this case?
Well, right now there is a pandemic. I know you know there's a pandemic. I don't mean it that way, but there's a resurgence of a pandemic in Connecticut. And unfortunately, I'm in a large facility where it's starting to increase again. And now we have another 40 cases of people, and we're short-staffed, and it's, I'm not allowed really to leave the state of Connecticut now based on the recurrence of cases, probably from this Delta variant.
All right, those are the only questions I have for you right now. Thank you so much, Dr. Schwartz.
Next, again, let me reiterate my objection with going forward with an evidentiary deposition at this point. But subject to that, I will go ahead and ask my questions today. Good afternoon. We can agree that Dr. Park was Mrs. Couch's primary care physician, right?
Can I just ask who you are?
Sure. My name is Tom Mazziotti. I represent Homestead Hospice and its employees.
Thank you.
Going back to my question, we can agree that Dr. Park was Ms. Couch's primary care physician.
Yes.
And he was her primary care physician for approximately 4 years prior to the hospice referral.
Yes.
Dr. Park was familiar with her medical history.
Yes.
Dr. Park was familiar with her medical conditions.
Yes.
He examined her.
Yes.
He spoke with her.
Yes.
In May 2017, he discussed her medical complaints with her.
Could you just repeat that? It's hard to hear you.
Sure, and I'm sorry. I'm trying to look for where is this it? Okay. In May 2017, Dr. Park spoke and evaluated Ms. Couch's medical complaints, true?
Yes.
And again, Dr. Park referred to Ms. Couch to hospice, right?
Yes.
Dr. Park is independent of Homestead Hospice. You understand that?
I do.
And as I understand, you disagree with Dr. Park's referral, true?
Yes.
On direct examination today, you discussed how you were board certified in internal medicine, right?
Yes.
You act as a primary care physician for certain of your patients, don't you?
Yes.
And I believe I've read that you have an outside practice dealing with primary care physician patients like Ms. Couch.
Right, just to clarify, it's not exactly an outside practice. I used to work through Masonicare, but it is a separate practice. Yeah. I mean, it's a practice for the patients in the continuum. Yes.
So you have a separate practice where you see patients like Ms. Couch.
Yeah.
Where you determine whether to refer the patient to hospice.
Yes.
Just like Dr. Park.
Yes.
You've not seen any evidence that Dr. Park is in any way affiliated with Homestead Hospice, right? Hospice, correct?
Correct.
He in fact testified he has no affiliation with Homestead Hospice.
Yes.
As we sit here today, you have not met Ms. Couch, right?
No, I have not.
You have not physically examined her?
No.
You have not spoken with her?
No.
You have not spoken to any of her family members?
Correct. I have not.
Do you agree with Dr. Park that a patient placed on hospice can still live several years beyond the 6 months of hospice?
So I try to think if I've seen it. I have, yeah. It's not impossible.
So you do agree with Dr. Park that a patient that's referred to hospice sometimes lives beyond 6 months, correct?
Yes.
And can live for years after that 6 months, true?
Yes.
And you've had patients who have been on hospice and then lived for years, true?
Yes.
Just because a patient that's on hospice lives beyond 6 months does not mean it was an incorrect placement to hospice.
Is that a question or a statement?
True?
True.
Now, today you're giving opinions in hindsight, right?
Yes.
And in this case, Homestead Hospice and its nurses evaluated and cared for Ms. Couch prospectively in real time, correct?
Yes.
And in this case, you understand you are to look prospectively when looking at this case.
Correct.
In your testimony here today, do you have any notes or any documents in front of you to refresh your memory or help you as you give testimony?
Right now, no.
How about during direct examination with Mr. Potts? Did you have anything in front of you?
No.
All right, I want to talk a little bit more about your background, okay?
Okay.
I think you said you went to medical school in Guadalajara, Mexico, and then you finished in the West Indies, right?
Yes.
Are you a medical doctor or is it a doctor of osteopathic medicine?
No, I got into an osteopathic medicine school, but back 40 years ago, I wanted to get an MD degree. I got on the wait list of some American schools, but decided to try to expedite it by going to Mexico. So both through Mexico and the West Indies, I got a medical doctor degree.
And so you're a doctor of osteopathic medicine, true?
No, I'm a doctor of allopathy. I'm a medical doctor. MD is my diploma, what my degree says, MD, not DO. DO is osteopath.
Understood. You work in a multi-level facility you described earlier, true?
Yes, sir.
It's an 80-acre campus in Connecticut.
You must have done research on it. I don't remember how many acres it is, but probably so.
If you testified back in 2018 that it's 80 acres, would that be correct?
Yes.
And as you mentioned, this facility has everything from independent living, geriatrics or elderly to hospice patients, right?
Yes.
It has over 400 beds.
Well, I mean, they're going down in their bed size, but that's what it had at the time. Yeah, correct.
So it's true, it has 400 beds as of today.
As of today, well, it had 380 beds, I guess, 360 beds, and had filed for an application to decrease to 280 beds or 240 beds. I'm not sure when that will go through because of the pandemic, but I know they're planning to decrease the size of the facility or at least remodel it.
It's not home hospice, is it?
It's not home hospice?
Correct. It's a facility, not at-home health
Oh,
care.
no, maybe I'm not making myself clear. The facility itself isn't home hospice, but there is Masonicare Home Health and Hospice as an affiliate of Masonicare itself. So it's a separate affiliate that goes with home care and dealing with patients in their homes.
Understood. I think you said a census typically has over 1,000 residents at this facility.
You mean in the whole facility?
That's correct.
Yeah, I think that's correct.
Talking about the qualifications for a medical director to be on hospice or home hospice, it's true that the standard of care does not require the medical director to be board certified in palliative care.
So I'm assuming you're asking me the question, right? Correct? Yes, that's correct.
Just to be clear, the standard of care does not require any board certification to be a medical director for home hospice.
Correct.
So you can be a medical director for a home hospice company without any board certification, correct?
Correct.
As far as your research and articles, you've never authored any articles on any of the issues you've discussed here today about over-medication, true?
No, I have not.
You are not a pharmacologist, correct?
Correct.
A pharmacologist would have more training on drug interactions than you.
I don't know if I can comment on that. I have knowledge based on my subspecialty certifications. I can't compare myself to a pharmacologist.
You're unfamiliar with a pharmacologist's level of training and experience, true?
Yes.
You're not a neurologist.
No, I'm not.
Not a registered nurse.
No, I'm not.
Not a licensed practical nurse or LPN, true?
Correct.
You have never given formal teaching in a classroom to a registered nurse.
I have given formal training to registered nurses in classrooms through, actually students come to our center from Southern Connecticut State University and Quinnipiac University Nursing School. And as part of my role, I do teach them. I work with nurse practitioners and Sometimes they're part of our hospice teaching team, sometimes geriatric assessment teams, but I do teach them various topics of hospice and geriatrics.
But you've never taught formally a class at a nursing school, true?
True.
You've never been in the shoes of a home hospice registered nurse, correct?
The answer to that is I'm not a registered nurse, but I've made many home visits with a registered nurse, so I know what it's like to be in their shoes.
You've never actually been a registered nurse in a home hospice situation, correct?
Correct.
You've never been a licensed practical nurse or LPN in a home hospice situation, correct?
Correct.
You've been asked this question before, and I want to know if you still agree with it. In any situation, there may be multiple ways to treat the same patient that would be within the standard of care.
Correct.
If I asked you to name the home hospice nurses here today, could you identify them in their specific role in June of 2017?
I could name, I don't know if I could name every one of them. It's hard to, but I think Mrs. Couch's primary care manager was Rachel, forget if it's Mackenzie, something to that effect, but I think Rachel Mackenzie. And I think that the nurse manager, she had a nurse manager, Chris Pilo or Pola, I can't remember the exact spelling of her name. In other words, if I saw them, I'd remember them, but I have to sit for an hour to memorize every single name. But I remember reading their names in the record.
Okay, I'm just trying to figure out if there was a way to go through each nurse to talk about them, but I think there's probably a better way to handle this. So let me start with this. The home hospice administrator, Myron Paul, you do not have any criticisms of him today, do you?
I don't really recall many his name mentioned very much.
So you have no criticisms of Myron Paul today, correct?
Correct.
Now, based on what you told us earlier, you understand there's different levels of training between a registered nurse and an LPN, right?
Yes.
And certainly a medical doctor has much more training than either a registered nurse or an LPN, true?
Yes.
For example, a medical doctor can prescribe medications where a registered nurse and an LPN cannot, right?
Correct.
A medical doctor can make diagnoses where a registered nurse and an LPN cannot, correct?
Correct.
And it's a medical doctor who makes the referral to hospice, not a registered nurse or an LPN.
Correct.
As we sit here today, you have no criticisms about the qualifications or training of the homestead hospice LPNs and registered nurses, correct?
Correct. But I'm just reflecting on their depositions to remember the qualifications because there are quite a few of them.
And I'm sorry, did you answer that? You have no criticisms of any of the homestead hospice registered nurses or LPNs training or qualifications?
Correct.
Let's talk about the role of the hospice nurse for a moment. A hospice nurse comes in and actually lays hands on the patient typically, correct?
Yes.
Evaluates the patient, right?
Yes.
Speaks with the family, correct?
Yes.
Reviews medication with the family.
Maybe just after a question, just say correct or something so I know to answer. Correct.
And I'll be honest, everything I ask you today is going to be a question. So I'll try to remember that. And if I don't say correct or true,
Okay.
just assume it's a question.
Sure.
So a home hospice nurse also has discussions with the patient on medication, right?
Yes.
And if the caregiver or the patient has any questions, the hospice nurse answers those questions, right?
Yes.
The hospice nurse receives orders from the physician, correct?
Yes.
And the hospice nurse is expected to follow reasonable orders, right?
Right. Yes.
I want to talk a little bit about what you talked about earlier on opioid naive. Have you ever used UpToDate in your practice to do any type of research?
Yes.
Is that commonly relied upon or referred to by physicians such as yourself?
Yes.
And it's a reliable source referred to by physicians to get more information about different medical conditions and how to treat these conditions. True? I'm sorry, you cut out. Is that true?
Yes.
Now, opioid naive is a definition that has variability in the medical literature, right?
I suppose it has some variability, yes.
Have you ever seen the definition that defining opioid naive as those who have not received opioids in the 30 days prior to the acute event or surgery?
Yes.
As a matter of fact, UpToDate defines opioid naive in that manner, doesn't it?
I don't know that because I don't recall that specific statement from UpToDate.
If UpToDate defines it in that manner, would that be a reliable source to rely upon for a medical director at a hospice?
Yes.
If we use this definition of opioid naive, you would agree Shirley Couch is not an opioid naive patient.
No, I wouldn't.
Even if we use the definition that we just described, that it's a patient who is an opioid naive patient is a patient who has not received opioids in the 30 days prior to the acute event.
Yes.
But you would agree Ms. Couch did receive morphine in the 30 days prior to her admission to hospice.
Yes.
So under that definition, if she received morphine within 30 days of being admitted to hospice, she would not be opioid naive.
And the answer is, I can't answer yes or no. I have to elaborate on this.
Well, what I'm trying to, just using I understand your definition you voiced earlier today, but I think we've established there's other definitions out there on opioid naive, correct? Is that right?
Yes, that definition applies to an acute event like surgery. It's different than somebody in it's talking about having an operation, some kind of a more urgent event, an acute change, not somebody that's in Mrs. Couch's situation. That's why there are different definitions that apply in different situations.
Okay. If UpToDate doesn't make that distinction, and we use that definition here today, you would agree that Shirley Couch was not opioid naive when entering hospice in June of 2017.
Object form of the question. It's already been asked and answered. Dr. Schwartz has already told you that is not applicable here too.
Okay, you can answer the question. That's just for the court, doctor. So the court will have to respond to that objection later, but you can answer my question.
He's already answered the question. I object. It's been asked and answered.
You can still answer.
Can I answer?
It's you don't.
Let me ask it again.
No. I object. He doesn't have to keep answering the same question over and over. Whether
James, respectfully, you asked
don't interrupt me again.
over and over again.
The answer you is up to him. I object. He's not going to keep answering the same question over and over, and he's already told you what's applicable and what's not. You're trying to mislead the jurors.
At any rate, that's for the court, Dr. Schwartz. So let me ask it again. Assuming the definition,
I object to you asking it again, and I object to him answering it again.
it's noted. Assuming opioid naive is defined the way UpToDate defined it earlier, that being a patient who has not received opioids in the 30 days prior to the acute event, you would agree Shirley Couch is not opioid naive, true?
Object to the form of the question. It's already been asked and answered. It's also not applicable here.
That would be my answer. It's not applicable in her situation. It was meant to be answered defined for an acute surgical event, not for the person on hospice.
Now move to strike that as non-responsive and also having attorney coaching the witness, but we'll move on. You would agree that Shirley Couch received oxycodone in the past, right?
I believe I recall that. I can't say I actually remember seeing that absolutely.
She received morphine in 2017, true?
Object to the form of the question. Are you talking about in June 2017 or some other date? And if so, what date are you talking about?
You would agree in her February 2000 admission to Piedmont Athens Regional Medical Center, she received morphine.
Object to the form of the question. What date are you talking about?
You
Mr.
can answer,
Mazziotti, what date?
you can answer the question.
Object to the form of the question.
I don't recall seeing that.
Do you recall that she had intractable pain in February of 2017 that led to her admission to Piedmont Athens Regional Medical Center?
No, I don't recall seeing that.
And intractable pain means pain that cannot be managed, true?
Yes,
She also received tramadol during that admission on February 1st, 2017, correct?
I don't recall seeing that.
Okay. What I'm doing is I'm going to pull up, or at least try my technological capabilities here today. All right. All right, what I'm showing you is record from Piedmont Athens Regional Medical Center. Now, as you can see, the admit date is February 1st, 2017. And then under number 3, it says intractable pain, correct?
Yes,
And then under, and as we discussed, that means that her pain was not being managed, right?
correct.
And then we've got a medication administration record here, and we go right here on February 3rd, 2017, she's receiving morphine, is that right?
Yes,
And then we go down some more. We can go to the next page. She receives tramadol, correct?
yes,
Multiple doses of tramadol, correct?
yes,
Multiple doses of morphine in this same admission, correct?
yes,
In March of 2017, she went back to Piedmont Athens Regional Medical Center, right?
I believe so. I don't recall some
And
of
she
those.
had recurrent urinary tract infections, correct?
Again, I don't know that I saw all of that record as much as it referred to more in a summary from Dr. Park or something, but I don't recall every specific.
But she was receiving tramadol, right?
Yes,
That's what this indicates.
yes,
And then she was also admitted in April of 2017 for urinary tract infections, or infection in a TIA. Do you remember that?
that she was getting tramadol for a urinary tract infection.
Well, that's what they have right here, isn't it? That she received tramadol, right?
I'm not quite sure why you'd give tramadol for a urinary tract infection. Usually you give antibiotics.
Well, my question is, they gave her tramadol in April of 2017, correct?
Yes,
And that's actually for her left knee pain and osteoarthritis. Did you note that?
that sounds familiar to me back then, yeah.
Yeah, you are familiar. She has significant left knee pain that she complained of throughout 2017, right?
Yes, I do recall that she had knee pain.
And she was receiving tramadol for that left knee pain.
Right, I don't think it was on a constant basis, but I do recall her being on it.
But she was on tramadol frequently in 2017 between January and June of 2017, right?
I'd agree with the word recurrently. I don't know how frequently.
And then you do understand that on May 13, 2017, she went to the emergency department at Piedmont Athens Regional Medical Center again, right?
I am trying to recall that from, again, there's a lot of different brief admissions she had, and I'm not sure that I saw that emergency room records. I don't want to just answer without seeing it.
Well, I'm showing them to you now. So
Okay.
if we look on these records, we'll see that she received morphine on May 13, 2017, correct?
Yes. It was one injection. Could you just go back so I could see how they gave it to her? So it says morphine, 5 milligrams in the right deltoid. So she got one injection, yeah.
So she received morphine on May 13, 2017, correct?
Yeah,
She received diazepam on May 13, 2017, correct?
yeah, it looks like she got a tablet, yeah.
So I read that correctly. All right. And then you would agree she also got some Valium again on May 13, 2017 at 3:23, right?
Yep, yes.
By May of 2017, Ms. Couch's health was declining. Would you agree with that?
I don't know that I could say that from the records I reviewed. She looked medically stable to me. She had old strokes and a history of recurrent deep venous thromboses, but she still appeared, and I had seen a picture of her at one point, like I think it was June 22nd, and she looked alert and didn't look particularly frail to me.
And that was the one taken while she was in hospice, as a matter of fact, correct?
Yes,
Well, then let's go ahead and talk about June of 2017. Now, we talked about it a little bit earlier today, so I'll try not to retread things. You would agree one purpose of hospice is for pain management.
yes,
And in this particular case, the Homestead hospice nurses were in touch with Dr. Shiver regarding Ms. Couch.
yes,
And that's what you want to see in a team effort, as you put it.
yes,
And the nurses received orders from Dr. Shiver, right?
yes.
All right, I'm going to share my screen again to help us out as we go through some of these records. Okay. Now, this is the order that you've talked about a few times today, the admission orders with the medications, but I want to point your attention to this line with sulfone-codeine. Am I going to read this right? Family states she, meaning Shirley Couch, can and has taken morphine?
Yes. There, yes.
What was the first date that you believe there was a deviation in the standard of care by anyone at Homestead Hospice, any of the nurses specifically?
Well, are you asking me about the nurses, or are you asking me about the deviation in the first place?
Yeah, I want to know, when was the first time you believe a nurse deviated from the standard of care?
First date. Well, I think what I would say is that from my review of the record, on her admission, Mrs. Couch, although she had some arthritis and may have episodically taken tramadol, or when she had a flare, may have episodically gotten morphine, there was no indication that she had that degree of pain that she would need a standing order for morphine that frequently and at that dose, let alone any reason that she would need Ativan or Valium or Haldol. In other words, she basically looked like a comfortable, or appeared from the chart and what I saw later, but doesn't matter. The point is, it appeared clinically from the chart that she was a medically stable lady who didn't need any of these medications. And I'm not clear why she needed them.
Well, her pain level on June 1st, 2017 was a 6, correct?
I don't have it memorized. If you say so, I'll agree with it, but I don't remember.
You would not disagree with me when I say her pain level was described as moderate.
I think I could recall that, but I'm not totally sure.
That she had severe weight loss of 12 pounds as of June 1st, 2017, admission to hospice.
I think I saw that written, yes.
And when she was admitted, the Homestead Hospice nurses had a conversation with both Paula Stuchel and Renee Bonner, right?
Yeah, I believe that's correct.
They expressed a thorough understanding of the medication regimen. True?
I believe that's correct, yes.
They understood the plan.
And I'm trying to memorize what it's hard to memorize a whole chart and everything you see, but I'm trying to recall it in my.
If there's anything that causes you any pain, and let me know and we'll pull up the specific record.
Okay.
But they understood the plan of care. When I say they, Paula Stuchel and Renee Bonner understood the plan of care as of June 1st, 2017, right?
Yes.
And during this process, whenever a registered nurse and a licensed practical nurse visited the family, the nurse would encourage the patient and the caregiver to call with any questions or comments. True?
Yes.
Now, on June 6, 2017, Ms. Stuchel voices concern about pain. Do you remember recalling that?
On which day did you say?
June 6, 2017.
I vaguely remember it. I can't say I remember who said what totally. So to answer completely, it's, you have to memorize every paragraph.
Understood. You don't disagree with me, do you?
No, I don't.
Okay.
It sounds familiar, but I don't want to.
And after all, we talked about this. You want the patient in hospice to be comfortable, correct?
Yes.
You don't want the patient to have any breakthrough pain from the pain medicine. True?
Correct.
And at some point, her pain begins to get a little bit worse. Is that right? At least what's been voiced to the Homestead Hospice nurses.
That's what's been voiced, yeah.
And then the Homestead Hospice nurses communicate, as they should, with Dr. Shiver, right?
Yes.
And then Dr. Shiver gives them orders on what to do next, correct?
Yes.
Typically, around 3 to 4 weeks into hospice care, that's really still early on in the hospice setting for somebody like Ms. Couch.
that a question? I'm sorry, I can't.
Again, all of my statements will be a question. I'll try to remember to say right or correct.
Yes, it's there.
But in this particular situation, you would agree 1 month in is fairly early on in a hospice stay, correct?
Yes,
I mean, in your experience, you're still adjusting the medications or the pain medications during this period of time, true?
yes,
And as a matter of fact, on June 26, 2017, the same day the family calls the EMTs, that's when Dr. Shiver begins to decrease the morphine, right?
so can you just repeat that and concentrate on the dates that you said?
And Dr. Schwartz, I saw our court reporter's face. I think you're cutting in and out some. So if you could try to speak up a little, I think she had a hard time hearing the end of your response there.
Just need to repeat the question.
Sure. And again, what I think might help us if I just go ahead and pull up a document. All right. Now this is Ms. Pippin's narrative note. And down here towards the bottom, I don't know if my cursor showing, and it says Dr. Shiver recommended to decrease the MS, which is morphine, is my understanding, by 0.05 each dose until patient comfortable and not too dizzy. Did I read that correctly?
It's hard to see, but that looks correct, yes. Oh, that's better. Thank you.
All right, sorry about that. Let me read it again. So explain to Amy, which is one of the family members, that Dr. Shiver recommended to decrease the MS, the morphine, by each dose until patient comfortable and not too dizzy. Did I read that correctly?
Yes,
And so Dr. Shiver is starting to titrate or reduce the pain medications at that time, correct?
that's what that statement says, yes.
And that was before the EMTs were called. Do you understand that as part of the chronology of events?
I wasn't sure what date that happened.
June 26th, 2017, between 4 and 5 o'clock. You understand that was before the EMTs arrived, correct?
Right, but then she was in a comatose state, so it kind of was a little too late to do anything. I mean,
You understand that Dr. Shiver was reducing the pain medication before the EMTs were even called, correct?
a few hours before they were called again when she was semi-comatose.
Is that a yes?
Object to the form of the question.
You can still answer.
Yes, with what I said.
As far as a patient and we call it in hospice settings, transitioning means they're on their way to passing and dying, correct?
Yes,
When a patient is transitioning, you see typically altered mental status, right?
yes,
You see them, urinating less, correct?
could be, yes,
There's labored breathing, true?
could be, yes.
Groaning,
Say it again.
groaning,
Groaning?
Groaning,
Okay, sorry, I couldn't hear you. Yes,
moaning.
yes,
It's not uncommon for patients to have hallucinations, true?
true.
There's difficulty swallowing,
Yes,
difficult to awaken,
yes,
erratic sleeping patterns, true?
could be.
Loss of appetite.
Yes,
All right, let's talk about when the EMTs arrive now, okay?
yes,
You agree you have not seen any evidence that an EMT removed 3 fentanyl patches from this couch, right?
and I haven't seen any evidence. I thought I saw it written somewhere, but I can't recall exactly where it's, so I can't say I absolutely did, no.
You would agree there is no evidence that Ms. Couch had 3 fentanyl patches on her when the EMTs arrived, correct?
I can't say that I saw that, no.
Well, so you agree with that?
Object from the question asked and answered. He's already answered that question.
You can still answer.
No, do you have another question? He's not going to keep answering the same question over and over.
I disagree. You can still answer.
You're not required to answer the same question again, Dr. Schwartz.
Let me ask a different question. You would agree no family member removed 3 fentanyl patches, correct?
I don't know who removed, that's what I thought. I don't know 100% that I could answer who removed the fentanyl patches, but I remember reading that there were 3 fentanyl patches found on her. That's what I remember. I can only tell you what I thought I saw.
You have seen no testimony under oath that anybody removed more than 1 fentanyl patch, correct?
I don't recall seeing that. I mean, correct. Sorry.
And you agree that 4 of 5 fentanyl patches remained in the box that contained the fentanyl patches?
I don't know that I can actually say I remember how many fentanyl patches were in the box that from the records I reviewed.
You would not disagree?
Yeah, I don't know.
So you would not disagree if the evidence is that there were 4 of 5 fentanyl patches remaining in the fentanyl box?
Right, correct.
All right, I want to talk to you about when Ms. Couch went to Piedmont Athens Regional. You would agree as a physician, you rely on the history provided in order to accurately diagnose a patient.
I rely on the complete history. In other words, the medications that I see and the clinical presentation of the patient.
If the history is incorrect, then there's a risk the diagnosis is incorrect. True?
It depends on how incorrect the history is.
If the history is that there were 3 fentanyl patches and there were actually only 1 fentanyl patch, that would be a material difference, correct?
Wouldn't make any difference in this case.
You would agree 3 fentanyl patches is much different than 1 fentanyl patch, true?
50 micrograms of fentanyl in an opioid naive patient is just as bad as 3. In other words, 50 micrograms of fentanyl, even 25 could kill somebody. So all I can answer is to say that, in my opinion, medically, even if she got 1 fentanyl patch at 50, based on her history with all those other medications, it was below the standard of care, and that's my professional opinion.
Move to strike. My question, though, is 3 fentanyl.
Object to the colloquy to the extent that move to strike. We're not in the presence of a judge. If you're doing that to try to intimidate a witness, I object to that colloquy. Do you have another question, Mr. Masonicare?
Am I intimidating you, Dr. Schwartz, with my motion?
Do you have another question?
Am I intimidating you from Atlanta, Georgia?
Not whether you are, it's whether you intend to, Mr. Masonicare. Do you have another question for Dr. Schwartz?
Dr. Schwartz, let me ask this question, see if I can get a straight answer. There's
Object to the whoa, object to the question. You're not going to make suggestions like that. Your comment regarding a straight answer, he's not answering that question. Do you have another question?
Dr. Schwartz, you agree that 3 fentanyl patches is a material difference than 1 fentanyl patch? With regard
to the question, it's already asked and answered.
You can still answer. He's just preserving this for the court, and one day we'll have to take this up. But in the meantime, I need to get an answer.
It's up to Dr. Schwartz whether he wants to keep answering the same questions over and over. I object to the form of the question. It's been asked.
I don't really feel like
and stop being obstreperous. We need to get through this, and we're going to have a disagreement. That's why we voice our objections on the record. and then we can deal with it in front of the court. In the meantime, let me state my question again so we can make it clear. You agree there's a material difference between 3 fentanyl patches and 1 fentanyl patch of 50 micrograms each on a patient, true?
Object to the form of the question. It's already been asked and answered.
Correct?
Same objection.
I don't think it makes any difference in this particular case because, as I said before, 50 micrograms is still a lethal dose, whether it be 150 or 50.
So if I understand your testimony, a 50 milligram fentanyl patch along with the other pain medications on board were lethal doses to Ms. Couch?
They certainly could be.
And in that context, you would expect Narcan to be given to a patient, true?
I would, yes.
Are you critical of the Piedmont physicians for not giving Narcan to Ms. Couch?
I can't say that I saw Narcan or didn't.
Not whether you saw it. Are you critical that they did not give Narcan to Ms. Couch when she arrived at Piedmont Athens Regional Medical Center?
And my answer to you is I don't have any proof that they didn't give it.
I want you to assume they did not give it. Well, first of all, you said you read the Piedmont Athens Regional Medical Centers, correct?
I did.
You also said that you reviewed, did you review any sworn testimony of Piedmont physicians in any proceedings related to this case?
I don't recall reading any statements that I've gotten to see about any Piedmonts.
I want you to assume the Piedmont Athens Regional Medical Center physicians, the ED physician, did not give Narcan when Ms. Couch arrived. If that is true, would you be critical of the emergency room physician?
Object to the form of the question. It's an improper hypothetical question. It leaves out facts not in evidence. It also assumes, it leaves out facts and evidence, also assumes facts are not in evidence. Subject to that objection, he can answer if he knows.
Are you critical of them for not giving Narcan in the emergency room for Ms. Couch if she had so much medication on board?
This is how I would answer that. I'm not here to be critical of Piedmont physicians, but if I were the physician, and I'm not an emergency room physician, but as a physician, if I saw her, I would give Narcan, yes.
And in the Piedmont Athens Regional Medical, well, just to be clear, you personally, if you were faced with Ms. Couch on June 26, 2017 at Piedmont Athens Regional, you would have administered Narcan, correct?
Yes, I would.
And the EMTs should have administered Narcan, correct?
I think that they should have, yes.
And in the Piedmont Athens Regional Medical Center records, I do not see any indication of a, quote, drug-induced coma as you've referenced today. Is there a diagnosis in those records of a, quote, drug-induced coma?
What I recall seeing was a statement, a note from the ER physician or the Dr. Singh, who stated that the patient was in I don't know if I think she used the word drug-induced coma, but over-medicated, severely dehydrated, but over-medicated. And again, I don't know if she exactly used the word drug-induced coma, but I certainly know that it was written that she said the patient was over-medicated and they tried to treat her through supplemental hydration.
So nobody at Piedmont Athens Regional Medical Center diagnosed a, quote, drug-induced coma, correct?
Object to the form of the question. It misstates facts and evidence.
Correct.
I believe that Dr. Singh diagnosed her with a drug-induced coma.
And you believe that's in Dr. Singh's note from the emergency room, correct?
Objection asked and answered. He's already answered that question.
Correct.
I thought I said I did, yes.
I didn't hear you then, so, okay. We'll let the record speak for itself. Is Enterococcus a bacteria found in urinary tract infections?
Yes,
And that's urinary tract infections in the elderly is common, especially in a patient on hospice, right?
yes,
That's a big concern for a medical director like yourself for your patient population, true?
okay. This isn't the yes or no kind of an answer, because generally in hospice, you treat you're not treating to cure infections, you're treating to keep somebody comfortable.
Okay, but it's certainly, my question though, it is a concern in your patient population that a patient can develop a urinary tract infection, correct?
Yes,
And a urinary tract infection can cause altered mental status, true?
yes,
And if you saw a lab that had Enterococcus growth, that would be indicative of a urinary tract infection, right?
not in and of itself, it would depend on the urine analysis, because you can get asymptomatic bacteriuria and just have bacteria in the urine without it actually causing an infection.
So what you're saying then is, in addition to a positive urine culture of Enterococcus bacteria, you would expect to see some type of clinical signs and symptoms, right?
Well, you do a urine analysis and you look at white cells and you see pyuria, you see a high amount of white cells in the urine.
And then you correlate that with whether there's clinical signs and symptoms of urinary tract infection, right?
Right,
And then an antibiotic is typically prescribed in order to resolve a urinary tract infection.
yes.
All right, let's talk about after Ms. Couch is discharged from Piedmont Athens, okay?
Yes.
As we sit here today, you're not aware of any complications that Ms. Couch has had since July of 2017 regarding this admission to hospice.
I don't know that, I don't believe I've reviewed further records that would tell me that, except that I knew she had some residual neurological impairment, difficulty using her mouth or swallowing or chewing.
And what document are you referring to on that?
To tell you the truth, I think it was either in the Athens record or something. I like a residual part. I don't know if it was a discharge summary from Athens. I honestly can't recall the exact part of that record. It was fairly big, but I do remember, I'm just trying to focus in my mind, but I do remember that she had some residual problems with her mouth.
You cannot say to a reasonable degree of medical certainty that Ms. Couch suffers from any injury related to the June 1st through June 26, 2017 hospice care.
I can't answer that without looking at more records that would show me what happened after she was discharged from Athens. I only can tell you I recall some residual neurological issues, particularly with her mouth, but I don't remember the specifics.
I'm going to have to take a short break. 5 minutes.
Once I finish this line, let me finish this line of questioning. I've got about 3 more questions, then we can break.
3 questions?
Anyway,
we're taking a break. I'm taking a break.
No, we're not. I got 3 more questions, and then we'll take a break. You read Shirley Couch's deposition, correct?
My lawyer just took a break, so am I supposed to keep talking?
No, he's still here.
Oh.
I said 3 more questions, then we'll take a break.
Okay.
Because I want to finish this just about this claim. You read Shirley Couch's deposition, correct?
I read parts of it. I don't know that I was able to have the time to read the whole deposition.
I want you to assume that she testified that she has no lingering issues related to the June 1st through June 26th hospice care. Based on that, you would agree to a reasonable degree of medical certainty there are no lingering complications. True?
If that's what she said, then that's true.
And then my last one, you testified about a neuroleptic malignant syndrome. You agree that Ms. Couch does not have neuroleptic malignant syndrome, true?
Right. From what I've seen clinically, she didn't.
Okay, let's take a break and then I'm almost done, doctor.
Well, that's good.
We'll take a 5-minute break.
The time is 6:32 p.m. We're
Oh,
now-
are you still asking questions in my absence?
The time is 6:36 p.m. and we're back on the video record.
All right, Dr. Schwartz, the court reporter was kind enough to read back those questions. Do you have any changes in your responses?
Oh, I just wish I knew my lawyer wasn't there and I wasn't supposed to keep talking and was told that I should. So that's my answer.
You know, typically in order to take a break, all attorneys agree, but subject to that, I understand. I'm going to give you a chance now. Would you change any of your responses to those questions?
No.
Okay. All right. Well, I'm going to shift gears now. Let's talk about your retention by Mr. Potts. My understanding is you are retained by National Medical Consultants. Is that right?
Yes. Can I just ask a question? Who's asking me questions now?
It's the same. Unless one of these nice young ladies developed a deeper voice, it's still me, Tom Mazziotti.
Okay. I just didn't see you there and I didn't know what happened. Okay.
I'm here in the top left. At any rate, so I think you described National Medical Consultants as kind of a matchmaker between attorneys and experts. Is that fair to say?
Yes.
And that's what happened here, correct?
I believe so. Yes.
And this service is specifically geared towards litigation, right?
Yes.
And this service retains a quote finder's fee, end of quote, when they retain an expert on behalf of an attorney, right?
I don't know. I believe they do.
I'm sorry?
I just know what I get paid. I'm sure they don't do it for nothing, but I don't know what they get paid.
If you testified earlier that they have a retain with they retain a finder's fee, would you disagree with that?
No, I believe they do. It's like if you were selling real estate and the
And
real
then you're paid, and I'm sorry, you're paid directly from this entity?
National Medical Consultants, yes.
And so the $3.75 an hour, that's what you get paid, but then they charge the attorney more than that for your time. Is that fair?
Right. Beyond that, I don't know what they charge. That's between them and the attorney. I just know what they pay me.
Okay, so they charge something more than your hourly rate you bill to them, right?
I believe so, yes.
When was the last invoice you submitted to National Medical Consultants?
Any invoice?
Yeah, what was your last invoice?
Maybe a week and a half ago.
And to the best of your recollection, how many hours as of a week and a half ago had you put into this case?
Well, to this case, I thought you meant a general invoice. You're talking about this case?
Yes, sir.
The last time I put an invoice for this case might have been, I know I was preparing for a deposition. I thought it was scheduled for around Memorial Day, which never happened. And I don't think I submitted an invoice for that because I didn't do anything except review the records. So I think, and that was, so I don't, it might have been like April or something for a brief attorney call, something like that.
All right, you've testified before that your income ranges annually between $50,000 to $100,000 a year from your medical legal work. Is that still true?
Yes.
So over the past 5 years, is it true you've made between $250,000 to $500,000 in medical legal work?
I think probably more like, yeah, I mean, not 500, but maybe 300 to 400, yeah.
All right, I'm going to reserve my right to re-examine Dr. Schwartz based on the motions that are pending, but at this time, I believe those are all the questions I have.
I object to any reservation. Do you have any additional questions, Mr. Mazziotti, today?
I probably will, but I'm going to let one of the other lawyers ask questions.
I have a few. Go next. Are you done? Good afternoon, sir. Can you hear me?
Who are you?
My name is Amy Cooper. I represent Ms. Carol Renee Bonner. Do you recognize that name, Carol Renee Bonner?
I do.
Okay. Based on your review of the record, you understand that Ms. Bonner is not a physician. She's not a medical doctor, right?
Right.
You also understand that Ms. Bonner is not a nurse, correct?
Yeah.
Based on your review of the records in this matter, you also understand that Ms. Bonner didn't go to medical school, correct?
Right.
She's not a registered nurse, correct?
Correct.
She's not a licensed practical nurse, correct?
Correct.
As a physician, you expect patients to be compliant with orders, correct?
I expect patients to be compliant with orders.
So if you have a patient and you advise them
I don't
to,
give patients orders, I give them recommendations.
so you expect your patients to be compliant with your recommendations, correct?
Yes.
But the same apply, I assume, the same would apply to patient caregivers, right?
Yes.
Would you have any criticism of Ms. Bonner if she administered medication as she had been instructed by Homestead Hospice?
Yes.
Would you have any critique of her as a medical professional?
You're going to have to speak slower. I'm sorry. I don't understand what you just said.
You wouldn't have any critique of her, though, as a medical professional, right? Because she wasn't one.
She wasn't a medical professional, no.
That's all I have. Those are the only questions I have for you, sir.
I'll take a break. What do you want?
Yeah, we can take a quick break, 5 minutes. Is that okay with you, Dr. Schwartz?
It'd be great.
Thanks.
The
Would you
time
like
is
to take a break, Dr. Schwartz?
And
Would you like to take a break or would you like to carry on?
how much more is there? I'm just asking.
I've got some questions. I don't know, I'll probably be half an hour or a bit longer.
I guess it's already 6:45. I guess we can keep going. If I start to get tired, I'll let you know.
All right.
Well, James, are you saying that you're not allowing me to take a break?
No, Mr. Mazziotti said that we took a break. Mr. Mazziotti, if he chose not to take a break, yeah, I don't know. I guess he didn't. He said quite rightly to adjourn a deposition. We all have to agree. So
And so I'm
Mazziotti
asking
wants
you, are you not agreeing? Is my point.
No, I didn't agree. We took a break. But what do you want, 5 minutes?
Yes, I would like 5 minutes. Are you extending the professional courtesy of a 5-minute break?
I am. 5
Thank
minutes.
you.
the time is 6:45 p.m. We're now off the record.
No questions at this
Oh,
time.
sorry. The time is 6:54 p.m. We're back on the
Dr.
record.
Schwartz. Oh, are we on?
Yes.
Dr. Schwartz,
Yes.
you agree that Shirley Couch was an opioid naive patient on June 1st,
Objection, leading.
2017?
Join.
I can't hear you. Can you speak up or get closer to the machine, please?
I absolutely do.
All right. Was Shirley Couch an opioid naive patient on June 1st, 2017?
Absolutely.
And can you testify to that to a reasonable degree of medical certainty?
Objective form, asked and answered.
You may answer.
Absolutely.
Yes, sir. Beyond that, how certain are you?
I am absolutely.
Objection.
Don't interrupt the witness. Dr. Schwartz, are you finished with your
James.
objection?
Excuse me, James, let me finish my objection and then the witness can answer. I object to the form of the question for the same reasons as I previously stated. Dr. Schwartz, you can now answer the question.
Join.
You may answer, Dr. Schwartz.
Absolutely.
I can't hear you, sir.
Absolutely.
Absolutely? Was that your answer?
Yes.
All right. Now, you're also licensed in the state of Florida, is that right?
Yes.
And does the University of Florida have a medical school?
It does.
And is that Shands?
Yes.
Is Shands part of the University of Florida system?
It is.
Is Shands a teaching hospital?
It is.
And do you think Shands publishes authoritative peer-reviewed articles?
It does.
I'd like to show you what we'll mark is, what number are we on, Madam Court Reporter, please?
We're on 8.
Thank you.
No problem.
We're going to call this exhibit number 8.
I'm just going to object to inappropriate use of medical literature with your own expert.
Can you see exhibit number 8, Dr. Schwartz?
I'm sorry, I couldn't hear the question.
Sure. Can you see exhibit number 8?
Can I see it? Yes.
Yes, sir. And are you familiar with Shands, the University of Florida's Drugs and Therapy Bulletin?
Yes, I am.
Do you consider that to be authoritative in the medical field?
Yes, I do.
You also consider it to be authoritative in the nursing field?
Yes.
You agree that just because you Google a medical term doesn't mean it's medically accepted?
Exactly. Yes.
And that would also apply to phrases like opioid naive?
Yes.
Can I Google opioid naive and just whatever the first search term that comes up, written by, somebody in the 3rd grade or just anybody else? Is that necessarily medically authoritative just because it's on a Google search?
No, it's not.
All right. And how would you define opioid naive?
An opioid naive patient is basically a patient that has not been on chronic, consistent opioid therapy for at least a week.
Yes, sir. And was Shirley Couch on chronic opioid therapy within a week before June?
No.
Was she on chronic opioid therapy the entirety of 2017?
No.
What about 2016?
No.
What about 2015?
No.
What about 2014?
No.
What about 2013?
No.
Is there anything in the medical records for Shirley Couch that you saw that suggested she was anything other than opioid naive?
Absolutely not.
Was there anything that you were asked on cross-examination earlier today that suggested to you anything other than Shirley Couch was opioid naive?
No, it just supported that she was opioid naive.
Yes, sir. And she was opioid naive in June 2017.
Absolutely.
And back to, and in addition to opioid naive, there's something also called an opioid tolerance, right?
Yes.
And so if you're opioid naive, that meets Shirley Couch meets that criteria under your definition and what you've used for 30 years and for the last decade plus as a hospice medical director. True?
Yes.
And there's also something that you cannot be opioid naive. Well, you can be what's called opioid tolerant, right?
Yeah.
And opioid tolerant is somebody who's actually taking opioids. Is that right?
Yeah.
Now, Shirley Couch wasn't taking opioids, right?
It was the opposite.
Objection leading.
So was Shirley Couch taking opioids?
Objection leading.
You may answer.
She was absolutely not taking opioids on any
All right.
regular basis.
So, and she was opioid naive.
She was absolutely opioid naive.
All right. Now, I want to show you the Shands article, and this deals with opioid prescribing in naive or tolerant patients. Do you see that?
You object to the use of medical literature inappropriately on your own witness without laying an appropriate foundation.
And it goes on to read.
Hold on, and would move to strike this being shown to the jury.
Join.
It goes on to read, for example, transdermal fentanyl, quote, patches, close quote. Do you see that?
I do.
And are transdermal fentanyl patches, is that what was applied to Shirley Couch when she was in hospice care in June of 2017?
Yeah.
And it goes on to read, should only be used in patients who are already receiving opioid therapy and who have demonstrated tolerance and who are not opioid naive. Do you see that?
I do.
Do you agree with that?
Ongoing objection to this line of questioning.
You may answer.
In fact, these are questions that are asked on hospice boards and geriatric boards and internal medicine boards because they are the standard and they expect board certified physicians to know this and to follow this in practice.
Yes, sir. And what questions are asked on the hospice boards and geriatric boards? What questions are you talking about in this regard? What are those questions?
Well, particularly the dangers of opioids in general, combinations of drugs, but particularly fentanyl.
Yes, sir.
And fentanyl. They give clinical scenarios of opioid naive individuals and multiple choices about, the dangers of fentanyl itself, and in various clinical, scenarios, trying to emphasize how dangerous this type of drug can be.
And one of those questions you're asked whether transdermal fentanyl patches should only be used in patients who are already receiving opioid therapy and who have demonstrated tolerance and who are not opioid naive. Is that right?
Yeah, exactly.
And the answer to that question is what?
The answer is that fentanyl patches should only be used in patients that have, it should never be used in opioid naive patients and only those with tolerance.
Right. And the Shands article goes on to read, giving potent long-acting opioids like a fentanyl patch to opioid naive patients has resulted in deaths. Do you agree with that, Dr. Schwartz?
Same objection.
Absolutely. And that's, again, a major topic on board examinations and in medical school education.
Yes, sir.
And even in courses that they teach in pharmacology in medical schools.
And do you teach medical students? Is that as well?
I do.
And what do you teach them about giving an opioid naive patient, or not even opioid naive, even someone that's not opioid tolerant, who hadn't been taking at least 60 milligrams of opioids on a daily basis, a fentanyl patch?
Object to the form of the question, misstates evidence, and to the extent it's already been asked and answered.
Join.
You may answer.
It should never be done.
And what can it cause if it is done?
Death.
All right. Is Shirley Couch lucky to be alive in that regard?
Object to the form.
Absolutely.
Why is she lucky to be alive, Shirley Couch?
Same objection.
It was like she was put on terminal sedation. And if I were a 400-pound football player and I got that much medication, I'd be in a coma.
Yes, sir. This article goes on to read, thus fentanyl patches should not. And you see how the Shands article has the only word in all caps there that I see in that entire article is not, N-O-T, not be used for acute pain. Is that right?
Absolutely.
And why is that?
Again, same objection to this line of questioning and showing and publishing this article to a jury when it's inappropriate to do so with your expert.
And it also misstates the amount of bold and underlined things are actually in that document.
You may answer, Dr. Schwartz.
Because fentanyl is a lethal medication, and it's not meant for opiate naive patients. And usually people that are in acute pain have acute pain because, again, they've never been on medications before. It's an acute episode, whereas with chronic pain, you might have long-standing opioid use and it would and possibly build up tolerance, but that was certainly not the case with Mrs. Couch.
Right. And back to exhibit number 8, the Shands article, it reads, opioid tolerance is defined in the fentanyl official labeling as those who take at least 60 milligrams of oral morphine daily. Do you see that?
I do.
And do you agree with that?
Absolutely.
And when we're talking about fentanyl, and are you familiar with a PDR?
Of course.
And what is a PDR?
Physician desk reference.
Yes, sir. And the physician's desk reference is a compendium of package inserts for drugs that the Federal Drug Administration puts out. Is that right?
Correct.
In other words, those are the instructions that come with the drugs, right?
Exactly.
And they've got warnings. Is that right?
Yes.
Sometimes what are called black box warnings. Is that right?
Right. Correct.
What is it?
Foundation leading.
And what is a black box warning, Dr. Schwartz?
A black box warning is basically a drug that has a very high risk of doing harm to an individual and
Yes.
possibly causing death if not used properly.
Right. And so a black box warning is there to alert physicians not to do something that can potentially harm and even kill a patient. Is that right?
Absolutely.
Objective form.
What does a black box warning alert a physician to do or not to do?
To use extreme caution with the drug, know that the drug could have a side effect as severe as death, to follow closely the warning on the black box as to how to properly use the drug.
All right. And on cross-examination, Sharonda Barnes said that Shirley Couch, if true, had been given some opioids in 2011. Do you recall that question?
I do.
Would that have any bearing whatsoever on Shirley Couch being opioid naive in June 2017?
Absolutely not. Totally irrelevant. Nothing to do with it. Absolutely not.
And Dr. Shiver's lawyer, Sharonda Barnes, then asked you about her being given opioids in 2013. Do you recall that?
I do.
Would whether she was given any opioids in 2013 have any bearing whatsoever on whether she was opioid naive in June 2017?
No, it's ridiculous.
All right. And then also in 2014, Sharonda Barnes, counsel for Dr. James Michael Shiver, suggested that she may have been given opioids in 2014. Would that have any bearing whatsoever on your medical opinion that Shirley Couch was opioid naive in June of 2017?
No, not at all.
Okay. And then Mr. Mazziotti, the lawyer for the hospice nurses, suggested to you that I think you pointed out the 5 milligrams of tramadol and some morphine that was given on hospital admissions, and that was in 2017. Would any of those have any bearing whatsoever on your medical opinion that Shirley Couch was opioid naive in June of 2017?
No, not at all.
Doesn't change your view at all?
I mean, Shirley Couch wasn't given narcotics on a regular, consistent basis, and certainly not at the doses that would cause her to be considered. She was definitely considered opioid naive.
Yes, sir. And I'm going back to Exhibit 8 now, the University of Florida Shands article. It reads here, do you see where the lowest underlined and in bold here?
Yes.
It reads, the 60 milligrams of oral morphine every single day is the lowest daily dose of opioid a patient must be receiving in order to prescribe the lowest dose of fentanyl patches. Do you see that, Dr. Schwartz?
In objection to the extent that it does not completely read the sentence.
And for the objections earlier about misusing literature with your witness.
And Dr. Schwartz, do you agree that 60 milligrams of opioids every single day is the lowest amount of opioids a patient can be receiving to be given even the lowest dose of fentanyl patch?
Yes, I do.
Sir?
Yes, I do.
All right. And now I want you to, now I know that Shirley Couch was opioid naive. She was not opioid tolerant. Even let's, not talking about Shirley Couch, but even an opioid tolerant patient, would you give that patient 4 opioids, including morphine, tramadol, hydrocodone, and fentanyl, and 2 benzodiazepines, including Ativan and Valium, and an antipsychotic like Haldol? Would that be okay? Let's just, if the patient was actually not opioid naive?
Just object to the form, not sure what the question is, and it's compound.
You may answer, Dr. Schwartz. You understand the question?
Absolutely. It's clear to me.
I can't hear you, sir. Can you?
Yes, I understand the question. It's clear to me, and I would not do that.
Okay. And is it below the standard of care for any physician to give that constellation of drugs to a patient, even if that patient's not opioid naive and opioid tolerant?
Object to the form of the question, asked and answered.
You may answer.
Yes,
That's below the standard of care?
it is.
And can you say that to a reasonable degree of medical certainty?
Yes, I
Same
can.
objection.
And beyond that, how certain are you, Dr. Schwartz?
Same objection.
I'm absolutely certain.
Yes, sir. And you used the phrase earlier, terminal sedation in a non-terminal patient. You mind explaining what you mean by that?
Yes. The terminal sedation is a very delicate kind of topic, and I guess it's used when you've tried every avenue and a person is dying uncomfortably. Generally, it's for people that have cancers that are metastatic to the neck or other areas such as this. Could be in an end-stage patient with, like they call it ALS, amyotrophic lateral sclerosis, or other end-stage neurological conditions. Usually it's somebody with a cancer in a very delicate area. We've had people with lung cancers, all kinds of cancers that metastasize. And basically, when you can do nothing else, and this is not something you do without a lot of discussion, you know, it's like it's a whole team discussion. You discuss with the family, because obviously if the patient has any sense of understanding, you would discuss it with the patient too. And basically it's not euthanasia. You're not killing the patient, but you're putting them in a terminal state of unconsciousness so that they die peacefully.
Right. And would you give us some example? I'm sorry, were you finished, Dr. Schwartz?
That was,
Would you give us some examples of terminal illnesses that would qualify a patient for hospice and make that patient hospice appropriate?
sure. Well, they're all different categories
Yes,
of,
sir.
of conditions. A person could have end-stage Alzheimer's disease or end-stage type of dementia, where they're no longer able to eat or drink, and they're not moving, they're not able to walk, they're not able to talk, and they're progressively declining in this regard. There are conditions with heart failure where a person has very severely depressed ejection fraction or heart function, where they're getting intractable shortness of breath despite maximal therapy. They can only walk, they can't even walk, even moving in bed or speaking causes them to be short of breath. Certainly cancers, and particularly, metastatic cancers, where a person is experiencing pain and really there's no other treatment, or blood, bone cancer, blood cancers, where they've maybe tried, chemotherapy or other types of therapy. They're not candidates for bone marrow transplant. End-stage neurological conditions where persons had long-standing Parkinson's disease, and they, again, are almost bedridden. They can't swallow from the degree of neurological impairment from the Parkinson's disease. Or again, if a person's had a stroke where they become, where they, the time of the stroke, they become totally unresponsive, can't swallow, they can't move, they're totally bedridden.
Yes,
That could be a condition. And there are certainly others, but those are the broad categories.
Yes, sir. And did Shirley Couch have anything remotely akin to any of those conditions?
No, she had the most recent thing she had was a stroke in 2013.
Yes, sir.
And otherwise, from everything I could see and past blood tests and whatever, was otherwise medically stable. I take care of a lot of people that have had strokes, unfortunately, and are certainly not hospice appropriate patients.
All right. Now, as a hospice medical director, do you ever get calls from physicians referring patients?
Yes.
And do they suggest to you whether they believe their patient to be hospice appropriate?
Yes. They would ask my opinion if they weren't clear.
Yes, sir. And ultimately, whose call is it? I mean, is it the non-hospice physician who makes the referral, or is it the hospice medical director who ultimately is responsible for making the call about whether that patient is hospice appropriate or not hospice appropriate?
Object to the form of the question. It's leading.
Join.
You may answer.
I mean, you don't have to lead me. I know the answer. It's the hospice medical director.
Yes, sir. Now, you were asked about Dr. Park and his certification of Shirley Couch as hospice appropriate. Is that right?
Yes.
And ultimately, whose call was it to make the determination about whether Shirley Couch was hospice appropriate?
The Shiver.
All right. And that's because his role was what?
He was the commander of the ship, so to speak, the medical director of the hospice program.
Right.
Just
Now,
as my role.
Now, you were asked on cross-examination whether you'd ever prescribed any of the drugs that Shirley Couch was given. Is that right?
Yes.
Have you ever prescribed all 7 of those drugs to the same patient?
Never.
Have you ever had a doctor that worked for you that prescribed those 7 drugs, those 4 opioids, 2 benzodiazepines, and an antipsychotic to a patient without psychosis that you know about?
No, absolutely not.
And what would you do if a physician that reported to you did that?
Probably put them in front of, I give them disciplinary action and have them, their practice monitored and the privileges reduced, and probably go through a formal hearing process for prescription practices.
Right. Now, you were also asked by Dr. Shiver's lawyer, Sharonda Barnes, about evaluating a hospice patient prior to admission. Do you remember that?
Yes,
And I believe you testified that you're not required to evaluate every hospice patient before every hospice admission. Is that right?
yes.
Now, is that the same thing as getting a call from a nurse about a patient needing more drugs and you prescribing morphine up to 480 milligrams a day, hydrocodone, tramadol, fentanyl, 2 benzodiazepines, Ativan, and Valium, and an antipsychotic Haldol to that patient? I know that's a hypothetical question because that would never happen. But is it below the standard of care for a physician to prescribe that constellation of drugs and, well, anything remotely akin to all those drugs and not go see a patient first?
Objection to the form of the question. It misstates evidence. It assumes facts not in evidence and is an improper hypothetical.
Yes, it's absolutely below the standard of care. First of all, to order that ridiculous combination of medications. And then secondly, to not evaluate a patient personally to find out why they need that kind of degree of medications. And I absolutely go and see patients. Again, we never prescribe to that level. That's why it's hypothetical. But if I had a patient that even came half that close, it didn't make sense why they needed that kind of medication, I see them, absolutely.
Yeah, and you evaluate before you start prescribing the drugs, not after, right?
Absolutely.
Because would it do much good if you waited until after you already prescribed the drugs and they were being administered to go see the patient then?
Object to the form of the question. It's leading.
Give me an answer.
No, it's just like the same question somebody asked me before about Dr. Shiver decreasing the dose of morphine when already the lady was in a coma and ready for just before the EMTs came. It's like nothing.
Yes, sir. I want to show you what we're going to mark as Exhibit 9. Exhibit 9. Have you ever seen this photograph before, Dr. Schwartz?
Yes, I have seen it before.
And you
objection to the use of this exhibit as it's not been properly entered into evidence or authenticated, subject to that objection.
Joined.
Do you recall seeing that as an exhibit to the depositions you reviewed in this case?
I do.
And you recall testimony that that's a picture of Shirley Couch taken on June 22nd, 2017. Is that your recollection?
It is.
I want to show you a picture of her taken 4 days later. All right, we're going to call this Exhibit 10. Is it 10, Madam Court Reporter?
Now,
It
the
is.
same
Yes, sir.
objection for this exhibit.
I'll join.
I'll show you what's been previously marked as Exhibit 10, Dr. Schwartz. Do you recall seeing this photograph?
I'll tell you, it's hard to look at, but yes, I do.
And do you recall whether that photograph was taken about 4 days later?
I do.
Objection to the form of the question lacks foundation.
And based on those two photographs, did Shirley Couch's health, her medical condition, improve or deteriorate in those 4 days or so?
Objection for the same reasons, and this question also calls for speculation.
Same.
Give me an answer, Dr. Schwartz.
I think deteriorate is a mild word. It looks like you went from an alert, peaceful patient to a patient near death.
Is that something you might expect to see when you give a patient 4 opioids, morphine, fentanyl, hydrocodone, and maybe tramadol, and 2 benzodiazepines, including Ativan and Valium, and an antipsychotic drug called.
Same objection, misstates evidence.
Give me an answer.
That would especially be true, particularly in an 81-year-old lady who's probably barely 100 pounds. And these drugs have an even higher absorption rate. When you have lower weight, the drug is almost twice as potent as if you're 100 pounds as opposed to 200 pounds. So in other words, what I'm trying to say is if you gave the same doses of these drugs to a 200-pound man as opposed to a 100-pound lady, they have even double effect.
Yes, sir. And I want to ask you now about home hospice care. And as a medical director, you also oversee home hospice care. Is that right?
Yes.
There was a suggestion on cross-examination that you did not, but that is, of course, false. Is that right?
I don't know where that suggestion came from, but I definitely do, and I try to explain that, but yes.
Yes, sir. And if you have dangerous drugs, and you agree that the opioids, benzodiazepines, and Haldol that was administered to Shirley Couch in June 2017 are all dangerous drugs, is that right?
Yes, yes.
And if you leave those dangerous drugs in the hands of an untrained person, not a physician, not a nurse practitioner, not a physician's assistant, NP or PA, not even an RN, not an LPN, somebody with zero medical training, who on the hospice care team is responsible for training that non-medical, non-nursing person to properly administer those drugs?
Well, the nursing staff.
Yes, sir. And that's the hospice nursing staff?
Yes.
And would that include all the hospice nursing staff defendants in this case?
Yes.
To the form.
And did the hospice nursing staff defendants in this case care fall below the standard of care in that regard?
Yes.
And can you state that to a reasonable degree of medical certainty?
Yes.
Beyond that, how certain are you?
Absolutely certain.
And did those hospice medical nursing defendants in this case, did their breach of the nursing standard of care cause Shirley Couch's drug-induced coma and ultimately her admission to Athens Regional Hospital?
Yes.
And is that to a reasonable degree of medical certainty?
Yes.
And beyond that, how certain are you?
I am absolutely certain.
All right. And is it proper to, I'm going to pull up an exhibit. One second. This has already been marked as Exhibit 2 to your deposition, which the defendants also showed you on cross-examination. Do you remember this exhibit? This is the physician's order dated June 2nd, 2017, signed by James Michael Shivers, MD, and Chris Pippin, RN. Do you see that?
I do.
And you see where it reads 6/2/2017 haloperidol?
Yes.
And that's referred to as Haldol for short. Is that right?
Yes.
And it reads haloperidol, 0.5 milligrams, take 1 tab. What does that say?
TO orally.
Yes, sir.
TO/sublingually PR, I don't know if that means PR. Oh, PR means per rectum.
Okay,
So it could be orally, sublingually, or per rectum every 4 hours as needed.
right.
And it
And
says,
that's, yep, go ahead.
it just says N and V means nausea and vomiting / agitation.
Have you ever prescribed Haldol for nausea and vomiting?
No, sometimes it works for hiccups, but not for nausea and vomiting.
All right, is there anything in the PDR or the package insert for Haldol that says it's all right for a physician to prescribe Haldol for nausea and Haldol, an antipsychotic drug for nausea and vomiting?
Well, may I say one thing?
Of course.
Okay, so if you look at the bottom and you see promethazine, right?
Yes, sir.
You see that? Promethazine is compazine. It's another antipsychotic like Haldol. And promethazine or compazine can be used for nausea, vomiting. You wouldn't
Right.
you wouldn't use two promethazine is also used as an antipsychotic and can also multiply the effects of Haldol. And it can cause, additional sedation. It can cause Parkinsonism and so forth. But you wouldn't. So in other words, you're basically right here using two antipsychotic agents, promethazine or compazine and Haldol or haloperidol.
All right. And what you need for nausea and vomiting, you need, is it called an antiemetic? Is that right?
Well, that's what the promethazine could be used
Right.
for, but you wouldn't use the Haldol and the promethazine. There's no reason to use them together. That's what I'm trying to say.
And was
Just-
that also, I'm sorry, was it also below the standard of care for Dr. Shiver to prescribe both the Haldol and the promethazine for nausea and vomiting?
Yes.
Objection to the form of the question, misstates evidence.
You may answer.
Yes.
And is that to a reasonable degree of medical certainty?
Yes.
Same
And
objection.
did that breach of the standard of care by Dr. Shiver also contribute to and cause Shirley Couch's drug-induced coma and for her to be taken to Athens Regional Hospital where she spent a week?
Same objection.
You may answer.
Yes.
Now, do you prescribe morphine for shortness of breath?
You can. It's not the first drug you would use. You might use, if somebody is very short of breath, a low dose of Ativan or lorazepam. But if they had, in other words, you generally would prescribe morphine for shortness of breath in a patient with a cardiac condition, such as heart failure, because morphine helps the circulation and may help heart failure. If they had coronary artery disease and they had shortness of breath from coronary artery disease, the morphine might help with the venous return and circulation in the heart.
Right. And when the way morphine was prescribed, you were asked about those prescriptions, and PRN, when it's as needed, and then it says up to a certain dose per hour, then that's the maximum dose you can use without contacting a physician, right?
Correct.
So opposing counsel, I think it was Ms. Barnes, said, well, this doesn't say give it every hour on the hour. Is that right?
Yes.
Does that mean that they don't get that amount every hour under that order without violating that order?
Object to the form of the question is cause for speculation.
You may answer.
If a patient had an order such as that,
I can't hear you, doctor.
if a patient had an order such as we were talking about morphine.
We'll pull it back up here so you can, we're looking at morphine here now.
20 milligrams, right?
Yep.
So the one that says morphine, 20 milligram per milliliter solution, take 5 to 20 milligrams. First of all, that's giving an extraordinary amount of leeway to anybody, particularly somebody who it's enough for a nurse to have that much leeway to decide whether you give 5, 10, 15, or 20 milligrams of morphine. So, I mean, that's an extraordinary variation in how much you can give. And then to say every 2 hours, it certainly gives discretion that you can give that every 2 hours. So
All right.
it's like a very broad and it's a very broad and actually dangerous order to give somebody, particularly a non-trained person that's going to administer it. We would never give an order like that.
Yes, sir. And then I want to go to the order that's on the June 24th. Now, this is when Dr. Shiver increased the morphine dose. It's the same amount. Let me make this. Can you see that all right, doctor?
Yeah, the very end of it's a little, after the shortness of breath, it's kind of cut out. I'll read
All right,
that.
let me, this is morphine 0.25 to 1 milliliters. And of course, that should read milligrams, not milliliters, right?
Well, not exactly. You give 0.25 to 1 milliliters of a 20 milligram per milliliter drug. So basically, so every milliliter is 20 milligrams.
Right.
Whereas
But isn't it? Yep, go ahead.
Whereas 0.25 milliliters would be 5 milligrams. So
Right.
it's just converting an oral concentrated solution from milliliters to milligrams, or the other way around.
Yes, sir. And that conversion, though, is it better for the doctor to leave that conversion to a nurse or even a non-medical or nursing person, or go ahead and put milligrams instead of milliliters and put 5 to 20 milligrams? Or does it matter?
Objection leading.
You may answer.
What we usually do is do both. We'll say 0.25 to 1 milliliter, make it clear what the solution is, like 20 milligram per milliliter, and then in parentheses say 5 milligrams to 20 milligrams. If in fact you were ever going to write 5 milligrams to 20 milligrams.
And back to what's been previously marked as Exhibit 3, where it reads, this is Dr. Shiver's order electronically signed. It's dated 6/24/2017. Morphine 0.25 to 1 milliliters by mouth every hour, PRN pain, SOB, that stands for shortness of breath. Is that right?
Correct.
Read back and confirmed. So that means Dr. Shiver confirmed that prescription, right?
Yes.
And it reads here every hour. Do you see that?
I do.
So that can be given every hour, right?
Right.
And that's within the order. Is that right?
Yes.
And Dr. Shiver ought to know that. Is that right?
Object to form.
Would it also be below the standard of care if he didn't know that that's what that order meant to everybody in the medical and nursing community?
Absolutely.
Now, you were also asked about Dr. Park prescribing tramadol in the past. Did whether Dr. Park prescribed tramadol in the past have anything to do with whether Shirley Couch was an opioid naive patient in June of 2017?
Absolutely not. Had no relevance whatsoever.
All right. And you're also, Sharonda Barnes, Dr. Shiver's lawyer, asked you whether you were paid for your testimony. Are you paid for your testimony or are you paid for your time?
Well, I'm paid for mostly my time.
Yes, sir.
If I do like a trial deposition, there's other fees I have to check because Gene kind of adjusted. I don't know what the current fee actually is, but it is an additional fee. Like, in other words, it's paid by the hour. It's
Yes,
$375 an hour that I get, and then it's a certain flat fee for a deposition or a trial, which again I have to confirm with him when we're finished. I was going to actually call his office and ask him what to bill.
Yes, sir. But you're getting paid by the hour, just like those Dr. Shiver's lawyer and the hospice's lawyer, right?
Yeah, yes.
And that you're getting paid by the hour, does that have any bearing whatsoever on you complying with your code of ethics and your, what you've spent, 40 years in education, training, and experience doing?
Of course not.
Okay. Would you, I mean, have you ever heard of, well, would it make any sense for a physician to color his testimony for $350 an hour when he's been practicing medicine for 30 or 40 years?
We object. He testified as $375 an hour.
Joining the
In
objection.
the state's fraud testimony.
I'll withdraw the question. Does the fact that you're getting paid per hour affect your testimony at all, Dr. Schwartz?
Absolutely not.
Sir, I couldn't hear.
Absolutely not.
All right. Cases, when lawyers call you about cases, do you tell lawyers whether they have a case or not in your professional opinion?
Yes, exactly. That's part of the role that I do working with national medical consultants. There are many cases that lawyers will run by me, and I will say that there either isn't a case. There are cases where I actually, if it's a case for that, that they're trying to have for the prosecution, I would say I think the defense practiced the standard of medicine. I don't think there's a case here. Right. And there are many times that happens. So, I mean, there may be cases where it comes out more that I'm seeing more for the prosecution than the defense. But the point being that there are many cases that never reach a trial or anything because I turn them down. I just say they don't have merit to them because I'm not going to sit here like I'm doing now for 5 hours and try to make a point where there is no point.
Right.
It's I don't need it at this stage of my life. I wouldn't do it.
And I believe you testified earlier that this was the most egregious case you've seen in 35 years.
Objection.
Objection leading.
It turns my stomach.
All right. Is that why you're doing this?
Yes.
Mr. Mazziotti, the hospice nurse's lawyer, used the word hindsight. Does that you were not physically there change any of the opinions that you've shared with the ladies and gentlemen of this jury today?
Of course not. I have experience. I can read the chart. I can tell what happened. And even if I knew nothing else, just to see this never seen in 35 years combination of these drugs in a 100-pound woman and seeing the picture of her going in 4 days from one fate, no disease process short of a cancer or some new major event, which she didn't have, would cause that to happen. It's medically impossible. And no matter what anybody says, no matter what anybody does, there is no way, and that's physical evidence, that lady could have gone from that state sitting there, no matter how much you work as a team, and no matter how many medicines she gets. That happened before she got all these terrible drugs in combination. When she finally ended up half dead, nothing. There is no medical condition that I know of anywhere that she could have gotten to that state in 4 days. And that's my main medical opinion of this horrible case.
Yes, sir.
The strike has been non-responsive.
And you were also asked by Mr. Mazziotti, he suggested you were not a pharmacologist, is that right?
Right.
And not a toxicologist, I think he said. And now, there are a lot of different drugs out there, is that right?
Yes.
And can a pharmacologist treat patients?
No.
Is a pharmacologist a physician?
No.
Do they have medical training like you do?
No.
Do they do a residency like you do to care for patients?
No,
Do they do fellowship training like you do to care for patients?
no,
Do they prescribe the drugs you do to care for patients?
no,
Are they trained to observe the signs and symptoms like you do of your patients?
no,
What about a toxicologist? Is a toxicologist a physician?
no,
Can a toxicologist care for a patient, I mean, legally without, being prosecuted criminally?
no,
Is a toxicologist licensed to prescribe drugs?
no,
Does a toxicologist have, do they go to medical school and complete a residency caring for patients like you did?
no,
Do they complete fellowship training?
no,
Do toxicologists or pharmacologists, are they board certified to care for hospice patients or geriatric patients or care for an internal medicine patient?
Correction, compound question.
You may answer.
no,
Oh, are either of them board certified to care for hospice patients?
sorry,
Yes, sir. Are either of them legally permitted to care for a hospice patient?
no,
Are either of them legally permitted to care for a geriatric patient?
no,
Are either of them legally permitted to care for a patient who needs the help from the care from a physician with the training in internal medicine that you do, being board certified in internal medicine?
no,
Now, do you supervise home hospice nurses? Is
yes,
that right?
yes,
And you have conversations with home hospice nurses about drugs?
all the time.
And do your home hospice nurses call you if they have a question regarding drugs?
We got 10 calls today.
Are your home hospice nurses trained to in turn train people in the home to administer drugs that you prescribe?
Yes,
And what do you do if a home hospice nurse doesn't properly or even adequately train someone in the home to administer a dangerous drug?
they're held accountable and their supervisors noted and they're acted upon accordingly.
Mr. Mazziotti shared with you a 30-day opioid naive rule. Does that have any applicability whatsoever in this case?
Absolutely not.
Mr. Mazziotti suggested to you that Shirley Couch had been admitted to a hospital for care in February, March, and May and received opioids. Does that any way whatsoever impact your professional medical opinion that Shirley Couch was an opioid naive patient in June of 2017?
Absolutely not.
Mr. Mazziotti also asked you about what he called breakthrough pain. Do you remember that?
Yes,
Now, if you have a hospice appropriate patient, like someone who's sadly dying of cancer and has pain, do you do what you can to manage that pain? What does that have to do, if anything? Well, what does that have to do with prescribing and administering 4 opioids and 2 benzodiazepines and an antipsychotic to a patient when there's no medical reason for any of those drugs?
Absolutely. And the only comparison or the only diagnosis that was made is she had osteoarthritis and chronic knee pain. And chronic knee pain and osteoarthritis doesn't warrant 4 opioids and 2 benzodiazepines.
Well, what does it warrant?
Tylenol around the clock, maybe.
All right. Anything it's more than that?
I mean, you know, I have a lot of patients. I take care of patients. Mostly some days it'll be 90, 95 years old and the body wears out over time. It's sad, but it's true. And I try to help people. And when people come to see me, you know, I never prescribe. I guess you can never say in medicine never, but I really don't ever prescribe an opiate. And I'm not talking hospice now, I'm talking about outpatient. But in my mind, he had the kind of pain that an outpatient patient that I would see in the office would have, where I would start with scheduled Tylenol. And maybe if that didn't work, I'd go with physical therapy and have the physical therapist do heat treatment and therapeutic pain modality and other types of treatment. And if that didn't work, I'd have an orthopedist see her and maybe do a knee injection, but I wouldn't give her 4 narcotics.
Right. Yeah. Much less 4
And 2
Okay.
benzodiazepines, 2 antipsychotics.
Now, Mr. Mazziotti also asked you, he picked some signs and symptoms and asked you about those on cross-examination. Is it true that the way you diagnose a patient is you take a constellation of signs and symptoms together, not isolated?
Absolutely.
And why is that?
Because a lot of people can have a cough, but a cough could be something from an upper respiratory infection, or it could be pneumonia, or it could be a sign of reflux esophagitis. So you take all the different symptoms together and you get the full picture of what's happening with a patient. If you take something in isolation, one type of isolation, you're not diagnosing properly and you're not treating the symptoms of the patient properly. You're not finding what the cause of the problem is.
Right. And you agree, I mean, that you observed enough signs and symptoms in the medical records that you reviewed that Shirley Couch needed at most Tylenol. Is that right?
Objection leading.
You may answer.
Based on what I saw, that's how I would treat her. Tylenol, maybe 950 milligrams 3 times a day around the clock. And if that didn't work, I'd probably go to the next level of physical therapy and as a later resort to an injection to the joint. Because no matter how much medication you get, if a joint is inflamed or painful or swollen, no amount of anything is going to touch it. If it's that bad, you need an injection or some other kind of intervention, but you don't need hospice.
Yeah. Based on the signs and symptoms that you saw when you reviewed the Shirley Couch's medical records and the deposition transcripts and exhibits in this case, what would you prescribe her? Have prescribed her?
I saw no reason for her to get morphine. I saw no reason for her to get Ativan. I saw no reason for her to get Haldol. I saw no reason for, I mean, I would start with Tylenol and I would start with Tylenol again around the clock. And if that didn't work, I might, again, the pain management in an older person is difficult because non-steroidal medicine like Motrin works well, but there are a lot of side effects in older people and that it can affect kidney function. It can cause bleeding in the stomach. It can cause confusion. So even a simple drug like Motrin can be very dangerous to an 80-year-old person, let alone these other drugs. So that's why we try to stick to a certain, and even Tylenol, they find we used to give 1 gram of Tylenol 4 times a day or 4 grams, and then they found that wasn't safe. And we've even gone down to below 3 grams. So I'm trying to say even a simple drug like Tylenol has warnings and side effects, let alone these extraordinarily dangerous opioids.
That's all I have, Dr. Schwartz.
Dr. Schwartz, I have a couple of follow-up questions for you. You just testified.
Can I ask you to identify yourself? It doesn't tell me who's talking, and I don't know who's asking me questions now.
My name is Sharonda Barnes, and I represent Dr. Shiver, okay?
Yes.
Okay. Does your answer to my questions, just for the record, does it depend on who you're speaking with?
Well, it helps me to know. It's nice to know who you're talking.
Form the question.
I just wanted to make sure it wasn't dependent upon who you were talking with. I just wanted to get that clear for the record.
I barely know. It just helps me to know where the questions are coming from, not anything else. Or who.
Understood. You testified earlier that you believe Shirley Couch was medically stable in the summer of 2017. You realize that out of all of the healthcare providers that have seen Ms. Couch during the time period of 2017, that you're the only person to give that opinion, correct?
No, I disagree completely.
Who else said that Shirley Couch was medically stable prior to her admission to hospice in June of 2017?
The doctor from Athens Medical Center, once she came out of her coma.
I asked, prior to June of 2017, who else stated that she was medically stable? That was part of her.
Objection. That said, what you testified, what your question was summer, and then you said June. Was that intentional?
No.
Object on that basis.
I think my question was clear. Prior to June of 2027, when she was admitted to hospice, can you tell me which one of the healthcare providers that were part of her healthcare treatment team described her as medically stable?
Only saw Dr. Shiver and Dr. Park that I recall. So I mean.
So the answer is no one, correct?
Yeah.
And those are the individual, well, first, Dr. Shiver didn't see her prior to her admission to the Homestead Hospice, correct?
Not that I'm aware of, no.
Okay. And it was Dr. Park who actually had the benefit of physically examining her, correct?
Yeah.
And treating her for up to 4 years, correct?
Again, I'm sorry, I don't know if you have a mask on, but I have trouble hearing you.
And treating her for up to 4 years prior to that time, correct?
Treating her at the park?
Yes.
Can you just ask the question again, please?
Dr. Park, who determined that she was not medically stable prior to her admission to hospice in 2017, not only did he have the benefit of physically examining her at that time, but he also had the benefit of providing medical care to her for the 4 years prior to that time, correct?
Yes.
When I was asking you questions, I asked you, what was your understanding of why Dr. Shiver prescribed Haldol? And you told me you believed it was because she was having agitations, and that was consistent with Dr. Shiver's testimony, correct?
Right. I'm not sure how much agitation she had on June 2nd when he prescribed it.
Well, thank you. But now when you were on redirect, you now testified that you believe that she was prescribed Haldol solely for nausea and vomiting.
No, it didn't say that. It said nausea, vomiting, or agitation in the order. I didn't memorize the whole order. I can't memorize the chart.
I'm not asking you to memorize the chart, but your specific testimony that it was a violation of the standard of care for Dr. Shiver to prescribe Haldol to her for nausea and vomiting, but that is not why he prescribed Haldol to her, correct?
Well, the order said nausea, vomiting, or agitation. I think, again, even you just showed it to me and I still can't memorize it, but I know it said nausea and vomiting, and I think it said agitation.
If you're going to object, I object. If you're going to ask him about a document, you need to show the witness a document.
I'm not asking him about a document. I'm asking about his former testimony. Would Dr. Shiver have violated the standard of care if he prescribed Haldol for agitation?
I can't answer that in isolation. He prescribed 4 other medications, 2 antipsychotic medications, as I pointed out, Haldol and Compazine, both for nausea, which, yeah, that's a violation. You wouldn't do that. Why would you order 2 antipsychotics, both for nausea and vomiting?
How much Haldol did Ms. Couch have in her system when she presented to Athens Regional for treatment?
I don't know.
Well, you stated to a reasonable degree of medical probability that the administration of Haldol in this case caused or contributed to her drug-induced coma. So please explain that opinion.
Absolutely.
Please explain that opinion.
Haldol, diazepam, Ativan, morphine, the past use of Norco, unbelievably high doses of fentanyl, all adding together to, it's not one drug in unison, it's all these drugs together contributed.
So can you tell me what amount of each of those drugs she had in her system when she presented to Athens Regional that contributed to her drug-induced coma?
No,
Object to the form of the question. Is that a joke, Ms. Barnes?
I don't need you to comment on my questions, but your objection is noted for the record. Do you have any
Object to
understanding?
the form of the question. Do you have another question?
He can answer the question that's on the table. Do you know, Dr. Schwartz?
no, I don't.
Okay, so as we sit here today, you can't say to a reasonable degree of medical probability if Ms. Couch even had Haldol in her system when she presented to Athens Regional Medical Center, can you?
I know she was administered it. I don't know how much she had in her system, no.
Okay, and you don't know how much morphine she had in her system when she presented to Athens Regional, do you?
No,
And you do not know how much tramadol she possibly had in her system when she presented to Athens Regional, do you?
no,
And you do not know how much lorazepam she possibly had in her system when she presented to Athens Regional, do you?
I don't know that anybody would know. Usually you measure urine levels of these drugs. What blood test is going to tell you how much of any of this is? It's not medically possible.
You don't know.
Nobody knows.
Okay. Thank you, Dr. Schwartz. I appreciate it. No, actually, I'm not done. You testified earlier, we'll strike that. You would agree with me that a certification of terminal illness is actually defined by statute, correct? By federal statute.
That certification of terminal illness is defined by federal statute.
Object to the form of the question. Misrepresents Dr. Schwartz's testimony.
I didn't say anything about his testimony. I asked Dr. Schwartz, are you aware that there are federal statutes which define what a certification of terminal illness is and when it must be executed as it relates to hospice patients?
There are guidelines in every disease that a person who is, not every disease, but there are guidelines, as I brought up previously when Mr. Potts asked me of different conditions that would qualify a patient for hospice, what those guidelines would be. And when I fill out a certification of terminal illness sheet on a patient, there'd be certain requirements that should be met. For example, Alzheimer's disease having a FAST score of 7C and a Karnofsky of 40. Or somebody with COPD having an FEV1 of less than 30. So that's my answer.
And you're aware that a certification of terminal illness is required by federal statute to be executed for hospice patients, correct?
And
And are you aware that actually a hospice medical director does not actually need to sign that form until the third period that a person is in the hospice program, correct? So a patient can be in the hospice program without being seen by a hospice medical director for a certain period of time, correct?
you're going to have to show me that, because the way that I know to practice and what we've done is on admission, the hospital's medical director or associate medical director fills out that certification of terminal illness.
How many certification of terminal illnesses do you say you complete in a routine week?
Well, we generally, I guess, probably about 20.
And would you say that all of those are completed on patients prior to their actually entering into your hospice program?
No,
Some of them are completed after your patients have been in the hospice program for some time, correct?
no. Everybody that's admitted to our hospice program is discussed every week. In other words, I have a meeting this morning. So patients that were admitted from last Thursday to this morning are discussed, the nurses present them to me with an interdisciplinary team, and I write a narrative based on what they're describing as to whether the patient meets or doesn't meet hospice criteria.
Right. Well, we've talked about that you don't always see patients at the beginning of their admission to the hospice facility, correct?
Most of the time I don't.
And so you also don't fill out that certification of terminal illness at the start of their admission to the hospice facility all the time, correct?
No, I do. What if I just told you within the week, maybe not the day, but within the week.
Right, but you're relying on some point and then to some degree that the physician that is recommending this patient for hospice and is also signing off on this patient for hospice, that patient qualifies for hospice care, correct?
Object to the form of the question.
Not just on the hospice physician refers the patient to our program. A nurse will evaluate the patient. A nurse will call me with her evaluation. There are times when a nurse will say, they referred this patient to us for hospice. They have Alzheimer's disease, but their weight is stable. They're not in any pain. We don't need, they're not having any significant change. Do you think this patient has a 6-month prognosis? This happens almost weekly, and I review it. And sometimes I'll say, yeah, what was the weight a year ago? Okay, it fell, let's do, and other times I won't have a reason, and I'll say, no, I don't think at this point it meets hospice criteria. So usually, I mean, I agree, I don't see every hospice patient before they're admitted, but the nurses run by what they find to me, and I give my opinion as to whether I think there's a terminal cause based on the guidelines I know from my board certification and my education.
Thank you, Dr. Schwartz. And that didn't happen in this case, did it? Everyone that was personally involved in Ms. Couch's care believed that she was hospice appropriate, correct?
Object to the form of the question. It mischaracterizes the evidence in the case.
Correct, Dr. Schwartz?
Same objection.
All I know is that nobody questioned it and she got admitted.
You're the only person who questions it, the person who actually has not ever seen Ms. Couch, correct?
Object to the form of the question.
How can I say I'm the only person that questions it?
I'm
an expert looking at these records, and yes, I question it very seriously.
Thank you, Dr. Schwartz. That's all I have.
Dr. Schwartz, this is Tom Assiotti. During the break before the redirect with Mr. Potts, did you have an occasion to speak with him?
Absolutely not. I went to the bathroom.
It was just that the two of y'all showed up at the exact same time. That's the only reason why I asked. As far as the list of materials you have reviewed, do you have any type of correspondence or inventory or anything like that personally that indicates what you've reviewed here today?
The only correspondence of anything I have is my affidavit or whatever I signed that I forget the exact term, but that says what I reviewed.
In other words, what I'm trying to find out is which depositions did you review?
I reviewed like 8 or 9 different depositions. Some I couldn't review as quickly. I can't remember every name, but it's in that document.
And that's what I'm getting at, that document. Do you have that document or is that with National Medical?
I don't have that document, no.
Who has that document? Or how can I lay my hands on that document is what I'm getting at. Would Mr. Potts have it?
I don't know, ask him.
Okay, with National, so you get your materials from National Medical Consultants directly?
I guess I don't really understand what you're asking me.
It's very simple. Do you get your documents from National Medical Consultants, the service?
Is that what you're asking me? I didn't know, even know what you were.
Hold on, let me finish. Just to make the record clear. Do you get your records directly from National Medical Consultants?
Yes.
And do they send a cover letter with it?
Sometimes. I mean, they don't generally send the cover letter. They just send records, and then they send a a form that lists a cover letter for, the name of the attorney and a phone number to call, and how much time I should spend on the case. And the preliminary time would be based on the volume of the records.
How much preliminary time did you spend on this case?
Preliminary time, I'm going to guess, I'm not guess, I'm going to estimate. maybe.
Object any guessing.
Yeah,
He's going to estimate. Go ahead. Finish your-
Right.
Object, no. Object any guessing.
yeah, I'm not guessing, but I would say an hour or an hour and a half.
Okay, if I understand what you're saying is you received the documents and National Medical Consultants puts a limit or cap on the amount of time you are to review documents, true?
I think the way that it's handled, and again, I don't want to, speak for how they do it, but I think there's an initial consultation with the director of this program, Dr. de Blasio. He kind of hears the situation and he asks attorneys to give the least amount of records to start with, just so that we can tell, as I told you before, if it's a viable case, if I think there is a violation in the standard of care. And rather than spending hours wasting time and money, when oftentimes, again, for both sides, there isn't a violation of standard of care. And I tell the attorney that it isn't something I can either prosecute or defend, then we get additional records.
So I am correct that when they send these records to you, there is a limit on the amount of time you are to spend reviewing the documents, true?
Yes.
Question.
And National Medical Consultants selects which records for you to review, correct?
Object from the question.
Incorrect.
But National Medical Consultants sends you the documents they specifically want you to review in a certain amount of time, correct?
Back to the form of the question.
The documents are sent by the attorney to Dr. de Blasio, who sends them to me.
Okay, so the attorney selects the documents then that they want you to review in this amount of time that's capped for your review, correct?
Correct.
And when you get these documents, you are told that this is being sent on behalf of a plaintiff, correct?
Could be a plaintiff or a defendant.
When you are sent these records, you are told that you are being sent these records on behalf of a plaintiff. Is that correct?
If it's on behalf of a plaintiff, yes.
So in this case, when you received the records from National Medical Consultants, you were told you were reviewing them on behalf of a plaintiff, true?
Yes.
In your disclosure, it references current medical literature. Do you know what that means that you've reviewed in this case?
But I haven't, the only medical literature I review is what I study on a regular basis to keep up with my board certifications, but nothing, not one specific thing, just multiple things.
And that's all I'm asking, just if there was something specific since it was referenced. Thank you. You understand in this case that fentanyl was prescribed for a chronic issue, not an acute issue, true?
I'm not clear on exactly, I not clear why it was prescribed. I don't think it should have been prescribed, and I have no idea why it was really prescribed.
Okay, Dr. Shiver answered that question. You just don't remember what the answer was. Is that fair?
I don't know why the fentanyl was prescribed. If he answered it, fine. I don't remember what he said, but I don't see why it was.
Okay. Now, you also mentioned earlier something about a nurse's job is to give appropriate instructions. And what I want to make sure is that we're clear for the record. I'm going to show you a narrative note from a June 24, 2017 skilled nursing note by Teresa Allen. And if you look down at the bottom here, continued education with daughter Renee present and Paula via phone. Verbalized understanding will call with any questions or concerns. Did I read that correctly?
What it says, yes.
And that's what you would have expected of a nurse to do to comply with the standard of care, right?
I suppose it would be one thing, yes.
Okay. If I understood you, you're not sure what you're charging today for your deposition for trial. Is that right?
Right. Tomorrow I will be calling, except that actually, well, doesn't matter. I have a busier day tomorrow, so it's hard to find when I'll have time, but I have to call Dr. de Blasio's office and discuss what they suggest.
Now, in the past, you've testified that your trial time is billed at $6,000 per day. Is that correct?
Yes,
You would anticipate then that this deposition would be billed at $6,000, correct?
that's what I have to check with Dr. de Blasio's office.
Have you ever billed less than $6,000 for trial?
Not that I recall, no.
You've testified twice at trial before. In each of those instances, did you bill for $6,000 an hour? That's my question.
Yes,
All right, when you find out from national medical consultants, please let Mr. Potts know so he can let us know what your charge is here today. Will you do that for us?
absolutely.
Okay, those are all the questions I have. Thank you.
I have no
Doctor-
additional questions.
I'm sorry. Did you have questions, Ms. Cooper?
No, I have no additional questions.
Dr. Schwartz, you reviewed James Michael Shiver's deposition.
Yes,
You reviewed Tracy Sorrow's deposition.
yes,
You reviewed Mary Pippin's deposition
yes,
and Mary Teresa Allen's deposition,
yes,
Christy Fowler's deposition,
yes,
Rachel McKnight's deposition,
yes,
and Ashley Mercer's deposition.
yes.
And do you recall that you were asked by Sharonda Barnes, Dr. Shiver's lawyer, about Shirley Couch's condition? You recall that she was actually cleared for surgery.
Correct, yes.
Is that right?
Objection when?
You may answer.
He was going to go for knee replacement surgery, and I thought it was earlier in the year, like March
And she was cleared for surgery, right?
of 2017, I believe. Yes, she was.
And have you ever heard of somebody being cleared for knee surgery when they had less than 6 months to live?
Objection.
No,
Why would you not clear somebody for knee surgery if they've got, just 6 months to live?
Objection. Misstates evidence talking about two separate and distinct time periods, but go ahead, Dr. Schwartz.
May answer, Dr. Schwartz.
knee surgery is an elective procedure, and you would never clear somebody for an elective procedure with a life expectancy of 6 months or less to live.
Right. And drugs like fentanyl, if you did blood work on a patient, would fentanyl even show up in the blood work?
None of these drugs would show up in blood tests. It's a clinical diagnosis, and many parts of medicine are to determine
Right.
clinical
Would
state.
you? Yes, sir.
No,
Did,
I'm-
did Shirley Couch have enough of these drugs in her system to put her in a drug-induced coma?
Objection. Calls for speculation.
You may answer.
From what I've seen from the record, yes.
That's all I have, Dr. Schwartz.
All right. I don't think there's any more questions for us. I join in Tom's request that we obviously have the right to reconvene at a separate time should we choose to ask you further questions, Dr. Schwartz, okay?
Yeah.
Thanks.
Have a good evening, Dr. Schwartz.
The time is 8:19 p.m.
Safe.
The position, we're now off the record.